Okay, so this is Elimination GI Part 1. So we're going to be talking about GERD, pancreatitis, and then an introduction to our GI system, which should be a refresher from your anatomy and physiology classes. So these are our objectives. I'm not going to read over all of them to save time for tonight. You guys can read over them on your own. All right, so just to review, when we eat, obviously our food enters the GI system in our mouth. It's chewed or masticated, and then before we swallow it. We swallow it, whoops. Sorry, lost my slide here. Okay, there we go. The food that we eat that contains starch, that is only going to be partially digested, and then it's going to mix with an enzyme called amylase. Our salivary glands excrete that. It's going to help break down our food. Our food is then going to move into the esophagus, which is a muscular tube that leads from the throat to the stomach. It is about 25 centimeters long. It extends from the base of our pharynx all the way down to our stomach. We have an upper esophageal sphincter, which prevents air from being able to enter the esophagus and the stomach. And then we have a lower esophageal sphincter, which prevents the reflux of food and fluids into the mouth or esophagus. Our actual stomach is located on the left side of our abdomen. It temporarily holds all of that food that we chew up and we swallow. While it's in there, it's being mixed with all kinds of different enzymes, breaking it down, preparing it to be into like a semi-liquid form, so then it can move over to the small intestine and start working its way out of our body. Our cardiac sphincter is the opening between the esophagus and the stomach. They call it the cardiac sphincter because it is close to the heart. It's made of muscle fibers. And there's a pyloric sphincter that contracts, which is the opening between the duodenum and the stomach. So in our stomach, we have secretions that are being made and released constantly. It's always happening, even if we're not eating anything. But once we start to eat something, that whole process, it speeds up and it increases, and we have a lot more secretions that are made because it has to digest, break down that food. So our gastric secretions do contain hydrochloric acid, chyme, which is turns our food, which is our semi-liquid food after the enzymes have started to break it down. It moves through the stomach and into the intestines through peristalsis. Our small intestine, the primary function is to absorb nutrients from that chyme. We have three portions of our stomach. So we have the duodenum, the jejunum, and the ileum. The duodenum is about 10 inches long. It's the first region of the small intestine. That area contains the opening for our common bile duct and also the primary pancreatic duct. This allows bile and pancreatic enzymes to enter and start breaking things down. The jejunum and the ileum together have a combined, they're about 23 feet long together. In the ileum, there's an ileocecal valve, which is at the distal end of the small intestine and the upper portion of the cecum. This works to regulate liquid into our large intestine, and it also prevents the reflux of feces and bacteria from going back into the large intestine. Our large intestine is about 4 to 5 feet long and about 2 inches in diameter. The primary function of our large intestine is to receive waste from the small intestine. It's going to help it propel towards the anus so that we can excrete it from the body. When it's in the large intestine, it absorbs water, some electrolytes, and also some bile acids. The structures of the long intestine are the cecum, the colon. So we have the ascending colon, the transverse colon, the descending, and the sigmoid colon. then you have your rectum, the anal canal, and then you also have your appendix, which is a very small blind tube that doesn't serve any purpose at all. And then we have our accessory structures. So these are our liver, our gallbladder, and our pancreas. And inside we have something called the peritoneum that encloses the liver, the gallbladder, the pancreas, and all the other abdominal organs to protect them and keep them safe. So our peritoneum, that is a membrane lining of the inner abdomen. It allows the abdominal organs to move. There is a small amount of fluid in there to allow everything to be able to move around without creating friction. Our liver is the largest glandular organ in our body. It does weigh about 2 to 3 pounds. It's located in the upper right quadrant of our abdominal area. And our liver does a lot of different things. So it helps to form and receive bile. It processes our vitamins, the proteins that we eat, our fats, and our carbohydrates. It also stores glycogen for energy. It helps contribute to blood coagulation. It metabolizes and biotransforms certain medications, bacteria, and even foreign matter. And then it can also form antibodies and immunizing substances such as GABA globulin. Our gallbladder is attached to the mid portion of the undersurface of the liver. It's a very thin wall that holds about 60 mLs of bile. Its purpose is when we ingest food, it causes the gallbladder to contract, and then bile activates all the necessary digestive enzymes and an alkaline fluid that helps neutralize the stomach acid. It contracts and pushes the bile out of the gallbladder. Then we have our pancreas, which is, it's two things. It's an exocrine gland and an endocrine gland. So the part of the pancreas that's an exocrine gland, it produces hormones, insulin, endocrine, sorry. The endocrine portion produces hormones, insulin, and glucagon. The exocrine portion produces various proteins, fats, and carbohydrate digesting enzymes. So exocrine gland is a gland that releases secretions into a duct or some type of channel in the body, and endocrine glands release substances directly into our bloodstream. Our pancreas does have a lot of different enzymes that we use during digestion. They're released in active forms and they're transported to the duodenum where they're activated and they help break down that food. All right, so health promotion, what are we thinking about when we're seeing patients that could have some type of a GI issue? Well, the objective of the history that we're going to gather is we want to identify the reason why they're there. So this is going to be pretty specific. So what is their specific problem? And then we have to try and figure out what its possible cause could be. So after they tell us their chief complaint, we're going to do that focused assessment. So if it's a GI assessment, we're really going to be doing a good assessment in the abdominal area, asking a lot of questions about food intake, things like that, stools, recent bowel movements, constipation, diarrhea, things like that. We also want to know about their nutrition status, how do they eat. We want to ask some questions about their elimination patterns and then any history that they could have had. Have they have a history of, ulcerative colitis or Crohn's disease or chronic diarrhea, things like that. So the focus is going to be on any abdominal pain. We want to know about if they have how's their appetite? Do they have issues tolerating their diet when they do eat? Do they have any nausea or vomiting? Are they suffering from constipation, diarrhea? Has it gotten to the point where they're incontinent of stool or any other GI questions or complaints? So when we do that physical examination, always we're looking at that snapshot photo. We're looking at their general appearance. So how do they look? Do they appear malnourished? Do they appear overweight? what's their energy level like, what's their attitude, their mental status, because we know just what we're learning in mental health, that their mental status could affect their appearance. We want to look at their age, and then we also want to look at their height, their body size, their hygiene. We also want to look at their skin. So we want to look to make sure that it's not any type of abnormal color. So we're looking for jaundice, which is that yellowish tinting. We want to look for any distended abdominal veins, a distended abdomen, any type of scars or spider veins. When we're inspecting the mouth, we're going to be looking for any redness or inflammation. Does the patient have any sores inside their mouth, any cracked open areas, any swelling? The mucous membranes can also show signs of jaundice, so we want to look for that. And do they have any missing teeth? When we're looking at the abdomen, we're going to make sure that we're particularly careful how we do our assessment, because we want to inspect, auscultate, percuss, and then palpate last, because we don't want to push anything and cause a change anywhere. And then if warranted, we would do an examination of the anus if there was an issue there. So things that we would look for would be any external hemorrhoids that you could see from the outside. Is there any skin tags or fissures? Fissures are small tears in the opening of the anal area. Depending on what's going on, we might want to get some type of a stool sample, depending on what the problem is and what we're looking at. So when we do that abdominal assessment, we want to make sure that our patient is in a good position so we get the most accurate assessment. So we want them to be supine, in the supine position with their knees slightly flexed. We want to look at the contour of the abdomen. So is it flat and soft, non-tender? Is it round and tender? Is it round and soft? Is it distended? Do they have ascites? So we really want to pay attention to the shape of their belly. And when we're palpating, we want to see if we are eliciting any type of pain. So are they saying it's tender? They don't have any pain. We want to make sure that we're listening to our patient's bowel sounds with our stethoscope. We're listening for hypoactive bowel sounds or hyper. Obviously, if they're hypo, it could be just that they're constipated. If we don't hear any sounds, it could be that they have a blockage. And then if they have hyper bowel sounds, it could signal that there's something going on there that's causing diarrhea. We should always auscultate before we percuss and palpate. We know that. So we always start in the right lower quadrant, moving to the upper right, to the upper left, and down to the lower left. And then we want to allow up to 5 minutes to hear any bowel sounds and take note of whether they are normal, hyperactive, or hypoactive. And then when we're doing a measurement of that abdominal region, remember we want to try and measure at the widest point, which is usually right at the level of the umbilicus or the belly button. So this is just a little display of how we measure here on the outside, but this is what's behind the stomach that we're looking at. So if we're listening in the right lower, well, we're getting a majority of that large intestine right there. The appendix is under there. We're going to get a small portion of that small intestine. Then when we go to the right upper quadrant, we could, you have the liver there, the gallbladder, part of the pancreas, tiny, tiny, small part of the stomach right there. And then when we go to the left upper quadrant, your spleen is up there, the majority of your stomach, and about another half of your pancreas. And then again, in the left lower quadrant, you have your large intestine and another half of your small intestine. So this is just some common abdominal complaints, some things where you might, based upon what you're seeing or what you're hearing, these might be the issues. You guys can take a look at that. All right. So a nurse is conducting an abdominal assessment. What is the rationale for palpating the abdomen last in the sequence when conducting an abdominal assessment? A, it's the most painful assessment method. B, it's the most embarrassing assessment method. C, to allow time for the examiner's hands to warm. Or D, it disturbs the normal peristalsis and bowel motility.
D.
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 Yes. Yes, D is the answer. All right, the nurse is working with clients with digestive tract disorders. Which of the following organs does the nurse realize has effects as an exocrine gland and an endocrine gland?
B.
B.
B? Yeah, the pancreas.
B.
Very good. All right, so what are some diagnostic tests or studies that we might do for our patients if we are trying to diagnose or rule out certain GI issues? Well, we might do radiographic studies. So depending on what they're doing, we can use radiographic studies to visualize certain organs in the abdomen. We can look at certain things in the chest or our GI system. We want to make sure they're in the proper location. We want to see if there's been any damage to them. When we do these radiographic studies, we can use a contrast media. And we can also do a fluoroscopy, which is used with the media to observe the shape and the contour of empty organs. And it shows when the when the contrast medium goes through them, it shows how these different empty organs fill up and how they get rid of the dye, and it can show any issues inside. We can do a barium swallow or an upper gastrointestinal series, also called an upper GI series. If we do a modified barium swallow, we do what's called a fluoroscopic observation. This is where we go in and they swallow the barium and we look at the structure and the function of the esophagus. If we do an upper GI endoscopy, it's going to look at the esophagus, the stomach, and the duodenum. So that modified barium swallow is really just looking at the function of the esophagus. And then we can use these studies to identify any kind of abnormalities with the esophagus, any issues that the patient has swallowing. They can give them this barium, and when they swallow it, they take pictures and it shows once they swallow it where it goes. Is it going into the lungs? Are they aspirating? Things like that. Very useful. We can do what's called an EGD. This is where the patient goes in and they have an examination of, they look at the esophagus, the stomach, and the duodenum. They have to have an endoscope that goes through their mouth to inspect and obtain specimens. They can do biopsies when they're in there, or they can just look around. Sometimes if they don't see anything, they don't need biopsies. A big thing with a patient that has an EGD is post-operatively. We just want to wait until their anesthesia has completely worn off and they're able to sit up and swallow again without any issues. So we want to hold all those fluids until that gag reflex returns. We could do a colonoscopy, which is a procedure in which a doctor uses an endoscope to examine the inner surface of the colon. So kind of like an EGD, but the opposite end. So preoperatively, patients that have colonoscopies, usually a day before, they have to take some type of bowel prep. Usually it's a mixture of a couple different things, some pills, which are laxatives, and then we can give them some, doctors just prescribe their own things. Some people get Miralax, some people get mineral oil, some people get something called Go Lightly. It's just up to the doctor. Usually the day before, when they start the bowel prep, they can have clear liquids up until midnight. So we always tell them clear liquids, but nothing red, purple, or orange, because that's gonna look like, it can make it look like blood during the test. So stay away from red, purple, or orange. And then at midnight, of course, they need to be NPO up until the time of their procedure. And then post-operatively, we want to, same thing as with that EGD, we would make sure that they're okay to swallow. Even though we didn't do anything there, they still had general anesthesia. So we want to make sure they're with it. We want to make sure they're not nauseated from the anesthesia. We start usually at the place, the colonoscopy place, they'll give you some clear liquid, some Sprite or some type of apple juice. And then they tell you when you go home, you can start on PO foods again, but it should be something light and soft. And you also want to instruct the client that there is going to be a lot of flatulence due to the fact that when they're under anesthesia, they have to put air. They inject air into the area where they're doing the test so they can move the different areas of the colon around so they can visualize what they need to see. And then sometimes their abdominal muscles may be tender from stretching during the procedure. So if they're doing that barium swallow or that upper GI series, we know that this involves that fluoroscopic study of that entire upper GI tract. So there's going to be radiographic observations, pre-procedural prerequisites. So 2 to 3 days beforehand, before they have the procedure, they have to have a low residue diet. About 8 to 12 hours prior to the actual procedure, they're going to be NPO, so nothing by mouth. They're going to take a laxative that evening before, and then we're going to instruct them that if they do smoke, that they cannot smoke because smoking actually stimulates the GI tract. So after they have the procedure, what we're going to do is we want to give them fluids. We want to make sure that we give a lot of fluids. So if your patient is NPO or they've had a stroke and they can't take in a lot of liquids, they're probably going to have some IV fluids for a while. The barium that we give for these tests is very, very constipating. So we're going to give those fluids. We might even have to give a laxative. The patients might notice that for a day or two after their procedure that their bowel movements can be white. They might even be streaky, or the patients might say they're like a clay colored. If we have to take any specimens and any type of stool specimens and send them off, we want to wait until that barium has been completely excreted. So once those bowel movements start to look normal again, then you can send out a sample. Failure for the patient to have a bowel movement within a reasonable time is something that you would definitely want to report to the physician, because if they hold on to that barium, it can cause a severe blockage. And then if we do a small bowel series, this is a fluoroscopy of the small intestines. So this is going to go in and look at issues or obstructions in the jejunum, the ileum. We can look for any kind of inflammation. We could look for any kind of lesions or tumors. This usually takes about 5 to 6 hours, and it's going to require that the patient swallow additional barium. So they're at even more of a risk for constipation. We can do something called an enteroslisis, which is a small bowel enema. This requires nasal or oral placement of a flexible tube that is then once it's advanced, it is positioned inside of the proximal jejunum. It does use 2 types of contrast media, and it takes about 6 hours from start to finish. We can do a barium enema or a lower GI series enema. This is where the patient gets about 1,000 to 1,500 mLs of barium injected into them, but it's going to be rectally. We will be able to go in then and take pictures, and it helps us look see if there's any polyps. So polyps left untreated can turn into cancer. If there's any tumors, is there any red inflammation, any red areas, if there's any strictures, and just any other kind of abnormalities in the colon. You can observe the rectum, the sigmoid colon, and the descending colon. It does require that the patient has changes different positions frequently. You're gonna want to make sure that they understand that they're going to be asked to change positions frequently, and that they're going to have to retain that barium for up to 30 minutes. So most people feel like that's probably a long time. They usually do pretty well with it. It's not an issue, but they do worry about holding fluid for that long. Again, if we were going to take any stool specimens, we would not want to do it until after the barium was completely expelled. And then the patient must follow certain restrictions and procedures to reduce the formation of stool and remove any residual stool. So again, we want to have a low residual diet 1 to 2 days prior. The evening before, we want them to have a clear liquid diet. We might give them a laxative, and then at midnight, they're going to be NPO, so nothing by mouth. So we could do an oral cholecystography, or they also call it a gallbladder series. We would do this if we thought our patient had gallstones, so it can help us identify any stones that are sitting in that gallbladder or in that common bile duct, or if there's any issues with the bile duct, it can also identify tumors, infections. What we do is we inject some type of a dye, usually iodine-based medium into them, and then into that area, and then we take pictures to see what's going on. Is our fluid not getting to the bile duct? Is it leaking from somewhere? We can see what's going on. If we have to do just regular radiographs, we would want to do them before we do other GI examinations. We want to make sure that the patient has a fat-free meal the night before the test. 10 to 12 hours before they have the test, they're going to swallow 6 iodine-containing contrast tablets. And then during the day of the procedure, we're going to go ahead and take those x-rays. A fatty meal or any fatty synthetic substance is given to stimulate the bladder contractions. Usually if we're doing the test, they're NPO, so they're injecting some type of synthetic fat into the patient to stimulate that gallbladder contraction. And then they take additional x-rays after that to determine how well the gallbladder empties or how it responds to the fat in the body. We could do a cholangiography. This determines the patency of the ducts that are in the liver and the gallbladder. So we would use this if the gallbladder was not distinctly visible. So maybe there was an issue with the liver, maybe the liver was enlarged and we couldn't actually see the gallbladder, we could do this. Or if the patient is vomiting. Obviously, if they're vomiting, it's going to interfere with them being able to take any oral dye, so we would have to do this. There are 4 different specific types of cholangiography. We could do an ERCP. We could do an intraoperative cholangiography. We can do an MRCP. So an endoscopic is the ERCP, and then the MRCP uses a magnetic resonance. And then we could do a PTC, which is a percutaneous transhepatic cholangiography. We would do those if we were putting in a stent or if we were doing any type of biliary drainage. And your book goes into a lot more detail about those 4 tests, so you can read about them in your book. We can also do radionuclide imaging. So we do this a lot if we suspect that there are lesions on the pancreas that we are trying to determine whether or not they're cancer. We can do it also for lesions on the liver. And we can also do it if we want to determine how our patient empties their stomach. Sometimes patients have issues with holding on to food and their gastric contents don't empty properly. So we could do this. If we think a patient has a GI bleed, we can also do this test as well, because it can help identify the sites of any inflammation that could be a potential bleed in the future, or if there's any areas currently where they're bleeding. And then when we do this imaging, we can either have the patient swallow it orally, or it can be injected into an IV if that's not an option. And then we can always do a CT, which we know is a continuous motion radiograph. It's 3-dimensional. It can detect any type of structural abnormality of the GI tract. It can also help identify metastatic lesions. If we're looking at any hollow organs, we want to make sure that we give them some oral barium sulfate, or you can also give them IV calcium phosphate prior to the test. Usually they should be NPO 6 to 8 hours before. And before the test, we would want to cleanse their bowels. So it might not be the whole entire meal, prep that we do for the colonoscopy, but you might see that they give them some Miralax or a couple pills about 8 hours before to get them as cleaned out as much as possible. So then we have non-radiographic studies which use energy instead of radiation. So that's your MRI. Some things to think about is that the patient must remove any metal objects. So you normally have to fill out a checklist. You have to go over all these questions with the patients. It's about 2 pages long, and it asks you all kinds of questions about, have you been a metal worker? Have you had any metal in your eye? Do you have metal in any part of your body? Different implants, things like that. So they can't have any metal objects on them or in them. They don't want to bring in their credit cards, no watches, no jewelry, no earrings. We do want to explain to them they are going to go into a very narrow tube that will enclose them during the test. So I always tell them that it's open at the top and the bottom, but they are pretty close to the tube inside, and that if they're claustrophobic, they might need some type of sedation. So you want to make sure you advocate for the patient and make sure that the doctor orders something that they can be given before they go down so that they can actually follow through with the tests. MRIs can be used to examine our GI structures, and we can also do oral contrast as well to get a better visualization of what we're trying to look at. We can do an MRE, which is just an MRI, but it's a lower frequency of sound waves. I've actually never seen that done. We can also do an ultrasound, which is high frequency sound waves that detect size of our organs and where our organs are located. It can help outline structures. It can signal any type of abnormalities, cholecystasis. It can help identify pyloric stenosis and any changes in the appendix. So if we think a patient has appendicitis, we could do an ultrasound. All right, so depending on what type of issues our patients have with their liver, if they have cirrhosis of the liver or we think they have some type of lesion or some type of a cancer, we can do what's called a percutaneous liver biopsy. This is where they go in and they take a small piece of the liver tissue, they examine it microscopically, and then they send it out to a lab for further clarification of what they found. We usually make the patient have a full round of coagulation studies done first, because one of the major complications that we worry about these patients having after this biopsy is bleeding. So we want to make sure that their coagulation status is normal and that they can make platelets and that they can clot appropriately. The physician goes in and they obtain what they call a small core of liver tissue by placing a needle through the patient's lateral abdominal wall directly into the liver. Usually these patients are just numbed locally. They don't usually go to sleep for this. We can use it to detect malignant changes. So maybe there was cancer there before, but now we think that it's gotten worse. We can also do it to identify some infectious or inflammatory processes that can cause damage to the liver. We can do this to detect liver damage. And patients who have had liver transplants, we can go in and take a portion and it can determine if the patient is rejecting their liver. You can look at your nursing guidelines on page 767. There's some more information there. We can do a gastrointestinal endoscopy. This is where we go in and we visualize the lumen of the GI tract. Kind of similar to the EGD, they put this very flexible fiber optic endoscopy tube down your throat to look at things. Hold on, I'm missing part of my slides here. So it helps you visualize the inside of the GI tract. It can look at the mucosa, see if there's any damage, if there's any lesions, anything like that. Looking for like diverticulitis, any kind of abnormality in the GI tract. So then, of course, there's always laboratory tests that we want to do. So we would want to do a complete blood count because we are looking for white blood cell count. Is there any sign of infection? Some GI issues are bacterial, can be caused by bacterial infections. We want to look at that blood count, the hematocrit, hemoglobin, platelets. Are they losing blood? Do they have a GI bleed somewhere? A urinalysis, we can look at the serum bilirubin levels. If there's any problem with the liver, those bilirubin levels could be off. We want to check cholesterol levels. They're made in the liver. Cholesterol is made in the liver. Serum ammonia levels, we're going to talk a little bit more about this, but patients that have issues with their liver, the liver can't work properly. It can't get rid of all the toxins in the body, particularly ammonia. So when that happens, the ammonia levels start to increase in the body and the patients start to be very, very confused. So we can look at that. We can look at the prothrombin time, which is one of the things we look at when we're looking at our patients' blood's ability to clot. We can look at electrophoresis and we can look at different enzymes. We can also, there are tumor marker studies that we can do that tell us if they suspect that there's some type of cancer in the body. We can also do a gastric analysis. So this determines any type of issues that we would have with the gastric, with the ability of the gastric mucosa to be secreted in the body, in the GI system. We can do a H. pylori test. Usually we take this specimen when they're doing an endoscopy. They wouldn't just go down for this. They would do a complete endoscopy while they were in there and check things out. H. pylori stands for Helicobacter pylori, which is a type of bacteria. We see this in a lot of people that have peptic ulcers. Hydrogen breath test, we can do this. It involves having the patient give a breath sample before and at different intervals after they ingest a special solution of carbohydrates. It's the same solution that we use with glucose tolerant tests. We do this a lot for our pregnant moms. If a patient has an elevated hydrogen level in the breath sample when they expired, it's going to indicate that they could have some type of carbohydrate malabsorption issue. We could also do a stool analysis. So we could look for a whole lot of things in the stool. We can look for some type of infection like C. diff. We could look for white blood cell counts, which could indicate infection. We can look for blood, which would mean that they have a GI bleed somewhere. And then if we have fat and mucus in the stool, it can indicate that there's a malabsorption issue. All right, what test should the nurse prepare the client for that will locate stones that have collected in the common bile duct? You guys didn't. D. Yeah.
I only know because I had that done.
Yes, an ERCP will locate the stones. All right. And the answers are on there. So, all right, a nurse is instructing a client prior to a colonoscopy. The client states, "Why do I have to drink this disgusting liquid?" The nurse is most correct to verbalize that the goal of the oral preparation is which of the following? To ease the passage of the scope during the colon, through the colon, to decrease pain associated with fecal matter being pressed against the colon wall, to cleanse the bowel to promote clear visualization of the structures, or to eliminate gas from the internal portion of the colon.
C.
Yep, C. You got to make sure everything's cleaned out so that when they go in there with the scope, they can visualize everything that they need to see. All right, so now we're going to talk about GERD, gastroesophageal reflux disease. So GERD is a very, very common disorder. A lot of people have it. It develops when our stomach contents backflow into our esophagus. So if you can see on this picture here, this is normally what happens. Our food comes down here on the left, down our esophagus, goes into the stomach here. This sphincter here stays closed and it keeps everything in the stomach from going back up. With GERD, you can see that that sphincter is more relaxed there. It's not keeping that area between the esophagus and the stomach closed. So all the stomach contents can go back up into the throat again. So it results from an inability of the lower esophageal sphincter, also called the cardiac sphincter because it's close to the heart, to fully close. It allows the stomach contents to flow freely into the esophagus. When the reflux is excessive due to an incompetent lower esophageal sphincter, pyloric stenosis, hiatal hernia, or excessive intra-abdominal pressure, the corrosive fluids start to irritate that esophageal tissue. The further exposes esophageal tissue to the acidic fluids, causing more irritation. So all of our stomach contents start coming back up, but then we also, when we don't have anything in our stomach, we're getting all that stomach acid that's constantly being made when we're not eating to come back up, and it really irritates the esophagus. Untreated, GERD can lead to inflammation, breakdown of the esophageal tissue, and then long-term complications such as Barrett's esophagus or adenocarcinoma of the esophagus. So patients that have Barrett's esophagus are at a high risk for developing cancer of the esophagus. If you leave it untreated, they will get cancer of the esophagus. So what are some assessment findings? So our patients may complain of dyspepsia, which is epigastric pain after they eat a certain type of food or drink some type of a fluid and have regurgitation. It can be different for each person. It's not always the same foods for everybody. Different foods bother people differently. They might say that they have a burning sensation in the esophagus. We call that pyrosis. They might be regurgitating, feel like they're throwing up in their mouth. Dysphagia, which is difficulty swallowing. This happens because that area gets so raw and the mucosa gets damaged that they have trouble getting food down. They may have painful swallowing, which is odynophagia. Inflammation of the lining of the esophagus, which is esophagitis. They might even be vomiting blood, hematemesis, and then melena, which is tarry stools. And then because of the acid coming up, it can actually erode the teeth as well. So who is at risk for developing GERD? Patients that are obese and pregnant. The extra weight causes extra pressure on the stomach and the diaphragm, and it pushes all that fluid through that sphincter, and it causes the reflux. Patients who have peptic ulcers, it causes reflux because the food does not move from the stomach to the small intestine efficiently. Patients that have a hiatal hernia, what happens is that it grows, it's actually like a little hernia. So as it starts to grow, it pushes on that esophageal sphincter and it can weaken it over time, allowing it to stay open and the food to come back up. Patients that have diabetes also develop something called gastroparesis, which is where it takes their stomach a lot longer to empty than normal. And then when that happens, it allows the contents of the stomach to reflux back up to the esophagus. We see it in patients that have asthma, patients that have sleep apnea. Sleep apnea and obesity go hand in hand. If we have a patient that has a nasogastric tube, that kind of makes sense because that tube is going through there and it's not allowing the sphincter to close completely. Chronic GERD can be a risk factor for developing Barrett's esophagus, which is, like I said previously, a precursor of cancer of the esophagus. All right, so how can we diagnose this? We can do a barium swallow. This can go in and look to see if the patient has some type of a hiatal hernia, if they have strictures in there or any other abnormalities that would cause that sphincter to stay open and them to develop GERD. We can always do an upper endoscopy with a biopsy, which is an EGD. This is done under moderate sedation. When they go in, they're going to look for any type of tissue damage in the esophagus, and they're going to dilate any strictures that are in there. We can do esophageal pH monitoring. I've actually never seen that done. It might be like in an endo center. It might be a specialty that they do. It's where they take a small catheter, they place it through the nose, and then it's into the distal esophagus. Then they take pH readings in relation to food that they eat, different positions that are in, and different activities that they do. They look at it over 24 to 48 hours. This pH monitoring is considered the most accurate method of diagnosing GERD. We can do a bronchoscopy, which is where we go in and we look down into the lungs. We can test for aspiration to see if they're aspirating on their food. We could take a stool sample looking for blood for a GI bleed. And then we could also do gastric emptying studies to evaluate the effectiveness of the stomach to empty its contents into the duodenum. So how do we treat GERD? So conservative measures are always what we like to do first. This, whether or not they can do that depends on the symptoms that the patient has, how severe they are, and how erosive how eroded the esophagus is when they go in there and take a look. They can do something called a fundoplication. This is where a part of the stomach that is closest to the entry point of the esophagus, which is, we call that the fundus of the stomach, it's gathered together, wrapped up, and sutured around the lower end of the esophagus and the lower esophageal sphincter to help create a physical barrier so that it can't come back up anymore. They can do something called a stretta procedure. I've never seen that done either. This is usually done in the outpatient endoscopic center, surgery center. It uses electrodes to create little tiny lesions on the lower esophageal sphincter. As those lesions start to heal, that tissue around there starts to tighten up and it increases the muscle mass and the strength of that lower esophageal sphincter to stay closed and help prevent the reflux. So pharmacological interventions, what could we do? So you guys would need to go to page 785 of your book. You need to know some of these medications. Where there are over-the-counter antacids that we can give. Some of you are probably familiar with them. We can give Tums, we can give Maalox, milk of magnesia, Rolaids. These help to neutralize the acid in the stomach. And then they also help to increase the pressure, the lower esophageal sphincter pressure. So we want to educate our patients that if they do take an antacid, they need to take it when acid secretion is at its highest because we want it to be that most effective. So usually acid secretion is the highest 1 to 3 hours after they eat a meal. And then if they do take them, you want them to take them an hour apart from all their other medications. We can give GI motility agents such as Reglan. This helps control the motility of the GI tract. You would want to use this very cautiously in patients that have Parkinson's because it decreases the level of the carbidopa and the levodopa that they take. Histamine H2 blockers. So this is Axid, Pepsid, Tagamet. It takes a little bit longer than the antacids for it to work and help control that acid, but it lasts longer. There's proton pump inhibitors, we call them PPIs, Acifex, Nexium, Prevacid, Omeprazole, Pantoprazole or Protonix, and then Dexilant are some of the common names that you will see. These work by reducing the acid and inhibiting the cellular pump of those gastric parietal cells that are necessary for gastric acid secretion. There is, studies are starting to show that there has been an increase in MIs, myocardial infarctions, community-acquired pneumonia, and colostrum C. diff infections with people who use PPIs. So just a little education teaching point. So lifespan considerations, we said earlier, it's a very common disease, prevalent in about 25 to 35% of the US population. Some nursing diagnoses that we may see for these patients are ineffective airway clearance related to reflux of gastric contents into the esophagus and tracheal or the bronchial tree, ineffective health maintenance related to deficient knowledge regarding anti-reflux regimen, so positioning, change in diet, acute pain related to that irritation in the esophagus from all those gastric acids coming back up, and then always a risk for aspiration, because anytime that entry of the gastric contents come up into the tracheal or the bronchial tree, there's a risk for aspiration. So things we would want to teach our patients, they're going to have to implement some type of lifestyle change. So we want them, since obesity is a risk factor, we want them to maintain a weight below a BMI of 30. We want them to have a diet that includes a decreased fat intake, and we want them to avoid large meals. They should avoid fluids and foods at least 2 to 3 hours before bedtime, so that way everything can be digested and we don't have to worry about it coming back up when they lay down. And then weight reduction is the way they're going to maintain that BMI below 30. They should keep the head of the bed elevated while they're in the hospital. If it's really severe, they can buy certain pillows that help keep their head elevated. We like the head of that bed to be elevated about 6 to 8 inches. So if they're in the hospital, you can elevate it. And if not, if they're at home, they can buy these special pillows. We want to avoid any tight-fitting garments that are going to put pressure on the stomach that can cause our stomach contents to come back up. And then educate our patients to stop smoking, because smoking increases our gastric secretions. So some dietary management, we want to encourage our patients to eat smaller meals and avoid foods and beverages that increase gastric activity. So black pepper, red pepper, regular and decaffeinated coffee and alcohol all increase that gastric activity. And there are certain items that they should avoid in their diet that lowers the pressure in that lower esophageal sphincter. So alcohol, chocolate, peppermint, licorice, citrus fruits, caffeine, and then high fat foods. All right, the client is ordered Tagamet, which is an H2 receptor antagonist agent for short-term management of GERD. Which of the following assessment findings is most important in determining care of this client? A, elevation of liver enzymes. B, smoking with use. C, uses antacids 2 hours after a dose. Or D, impotence.
Okay.
So it is A. So cimetidine has a higher risk of drug interaction than other H2 receptor antagonists, and it can cause elevated liver enzymes. Okay. All right. A patient diagnosed with esophageal reflux disorder has been admitted to your floor. When planning teaching for this patient, what should you advise the patient to do? Keep the head of the bed lowered, drink a hot cup of coffee, hot cup of tea before bedtime, avoid carbonated drinks, or drink a carbonated drink after meals.
I think it's D.
C.
I think
D.
it's C.
I think it's C.
Yes. So remember a couple slides back, we said that they want to avoid carbonated drinks and caffeine and tobacco. All right. So now we're going to talk about pancreatitis. So pancreatitis occurs when the pancreas becomes inflamed or when the organ's own enzymes, especially trypsin, cause the pancreas to digest itself. When that happens, it's called autodigestion. Inflammation of the pancreatic tissue causes obstruction of the pancreatic duct, which then can lead to increased pressure. It can cause the duct to actually rupture, which then causes the release of pancreatic enzymes into the pancreatic tissue. It will cause an impaired ability to be able to metabolize carbohydrates because of the endocrine cells in the islet of Langerhans are now malfunctioning. It can result in pancreatic inflammation, possible necrosis, and also hemorrhaging. So we can have acute pancreatitis and chronic pancreatitis. So acute pancreatitis is an inflammatory process that comes from activated pancreatic enzymes, that autodigestion in the pancreas, ranging from mild symptoms to necrotizing hemorrhagic pancreatitis. So it can just be mild inflammation and irritation, or the pancreas itself can become completely necrotic, not getting any good blood flow, and it can also hemorrhage. So it would be widespread. Then we have chronic pancreatitis. So this is a progressive disease, takes a lot longer. It is a destructive disease of inflammation and fibrosis that happens in the pancreas. It's classified as chronic calcifying pancreatitis. We usually see this with our patients who have alcohol disorders. And then we can also call it chronic obstructive pancreatitis, which is often associated with cholestasis, and autoimmune pancreatitis, which is caused by autoimmune disease. So you are going to find information about pancreatitis in chapter 47 of your book. So with acute pancreatitis, you can have a mild form and a severe form. The mild form, like we said, is just inflammation and edema, redness, swelling. Usually the pancreatic function can return to normal within about 6 months. In the severe form, we see that enzymatic digestion of the pancreas. We see that necrotic tissue start to form, and then it's going to cause local and systemic complications. The mortality rate in the United States is about 10% per patients diagnosed with this severe form of acute pancreatitis. So the pathophysiology and etiology, so we have that autodigestion, which is where the pancreas's own enzyme trypsin causes the pancreas to digest itself. It causes swelling of the pancreatic ducts, which obstructs the ability of the duct to release biocarbonate, which helps neutralize chyme as it enters into the small intestine. It also is going to obstruct the release of those enzymes, trypsin, which helps to digest proteins in our food, our amylase, which helps digest our carbohydrates, and then our lipase, which helps digest our fats. And then all of this together is just going to cause a complete destruction of the pancreas. So what can cause acute pancreatitis? So if a person has an abdominal injury, so if they're playing sports or if they're in a fight or a car accident, they have a crush injury, any kind of abdominal injury. If they have an issue with alcoholism, they frequently ingest alcohol. We see this with patients that have cystic fibrosis, patients who have gallstones. It can also be genetic, so a family history of pancreatitis, patients that have high triglycerides, kidney failure, lupus, which is that autoimmune disorder. We see it in pancreatic cancer, infections, hyperlipidemia and hypercalcemia also can cause pancreatitis. If the patient has vascular abnormalities, because it can cause the pancreas to become necrotic. We see it with inflammatory bowel disease. When we give patients tube feeding and we do that refeeding after they've had a prolonged period of fasting or anorexia, And then sometimes it just develops without any type of predisposing factors or they can't even identify any causes. It just happens. So what are we going to see in our patients? These patients are in a lot of pain. The pain is very, very severe. The pain is constant, and it usually comes on very, very quickly. And that's a pretty common finding with all patients. These patients are almost all the time on some type of IV pain medicine. For one, they're NPO because they can't have anything by mouth because we're doing bowel rest. That's the only way to fix it. But this is extremely painful. So they're usually getting pain medicines through their IV on a regular basis. They're going to complain of severe mid-abdominal to upper abdominal pain that radiates into the sides and the back. So that's important. You guys need to know that. They complain of mid-abdominal pain, mid to upper, and that pain is going to radiate to the sides and the back. They might be vomiting, and they also might have a lot of gas. If they do have a bowel movement, their stools are very frothy and they smell terrible. This can be a sign of steatorrhea, which is increased fat in the stool. Because remember, the body's not breaking it down. The enzymes aren't being released. So when we do our physical examination, because all the ducts are blocked, that bilirubin is building up in the body. So the patient may present with jaundice. They may have diminished or absent bowel sounds, and their abdominal region is going to be very, very rigid. They could have abdominal distension, and when you're palpating, it could be tender, depending on how far the infection has gone. They could have hypotension, hypovolemia. They could have a fever and tachycardia. These are signs of sepsis. They could also have bruising around the umbilicus or in their flank area. We normally see that with severe pancreatitis. When we're looking at diagnostic findings, so you're going to look at a lot of enzyme levels. So we're going to see a normal serum and urine amylase, lipase, and liver enzyme levels. Our normal serum amylase should be between 23 to 85 units per liter. Obviously, it's going to be just a little off here or there, depending on what facility you work on. Any value greater than 450 is going to indicate that there's some damage with the pancreas. When a normal serum lipase is 0 to 160, and any thing greater than 400 is also going to indicate pancreatic damage. These patients are going to have elevated blood glucose levels. You guys need to know this. You need to know why. So the blood glucose levels are going to be elevated because there's an imbalance between glucagon and somatostatin. Somatostatin is that hormone that is secreted by the delta islet cells that help maintain that constant level of blood glucose. They work to inhibit the release of insulin and glucagon. So there's an imbalance between those two. So these patients have elevated glucose levels, hyperglycemia. They have elevated white blood cell counts because of infection. They're going to have low serum electrolyte levels, mainly calcium, potassium, and magnesium. We probably are going to do a CT scan to look at the pancreas to see how inflamed or enlarged it is. And then they can also do an endoscopic examination where they go in and take a look at it. If we do a CT, we would be able to see swelling, also called pancreatic edema, and any type of necrosis. We could also do an ultrasound and an MRI. And then we could also do stool samples that test for fat in the stool. So what are we going to do to manage these patients? So the main thing we're going to do is to relieve their pain. And the only way that we can do that is to reduce the pancreatic secretion. So this is why we make them NPO. If we eat something, the pancreas is going to start secreting those enzymes again because it thinks it has to break the food down. So we make them NPO, the pancreas is at rest. We give them fluid to maintain their electrolyte status, or we're giving it to restore fluid, depending on if they were septic or what else is going on with them. So we want to restore fluid and electrolyte losses. We're going to treat those systemic complications. So if they're in respiratory distress, if they have any tubular necrotic issues in their kidneys, if they have any bleeding disorders, they're going to be NPO. If they have a lot of distension and if they're vomiting or extremely nauseous, we might have to put in a nasogastric tube because we can get rid of that. We can suck out everything that's in there to keep them from being nauseated and distended. So we're going to give them fluid therapy. We're also going to give IV albumin because sometimes in pancreatitis, fluid will get trapped in the peritoneum and it doesn't serve any purpose. So we want to pull that fluid out of the peritoneum, put it back into the circulation. So remember, albumin is like a water magnet. So that's why we give the IV albumin. But sometimes when we pull that fluid back into the circulation, what do you think we can cause? Fluid overload, too much fluid. So then we have to give them diuretics because now we pulled too much fluid back in. We can give atropine or other anticholinergics. These are going to help reduce the activity of the vagus nerve. Antibiotic therapy. Sometimes we do it prophylactically because we want to prevent any type of infection. If they have any abscess or anything on the pancreas, we would give it to treat that. And then of course, if they were septic, we would give it to treat the sepsis. So then their diet therapy, we're gonna, like we said, control it with NPO at first. After those enzyme levels start to level off and start to return to normal, then very slowly we give just a clear liquid diet. That would be for like a day or two. Then we move to a full liquid. The diet is really advanced, pretty gradual, more so than in other disease states, because we have to really monitor those enzymes and make sure that it doesn't reoccur again. And then sometimes we could have to go in and do some type of surgical intervention if need be. So for pain, like I said, they're going to be getting opioids, morphine, Dilaudid, fentanyl for pain. We can also give medications to help stop the gastric acid production. So we could give Pepcid or Prilosec. All right, so what do we want to monitor as nurses? Well, we want to monitor for any type of life-threatening changes. So if these patients have pancreatitis because they have an issue with alcohol, well, we're obviously going to want to watch them for alcohol withdrawal because they're not having anything by mouth, not even alcohol. So if these patients are usually used to drinking every day, so we're going to do seizure precautions in the room, line that bed with towels or some type of padding that you have at your hospital. So in case they have a seizure, they don't get hurt. You're going to be doing those CWAs, which are where we ask the patients different questions every 4 hours and look at their vitals to determine if they're going through withdrawal. We're going to perform any prescribed treatment. So if they need fluids, we're going to give fluids. If we have to insert an NG tube, we're going to do that. Make sure we're doing those thorough physical assessments on our patients. We're going to do a very detailed abdominal assessment. We want to monitor to make sure the patient doesn't develop a paralytic ileus. This is where the intestines become paralyzed and peristalsis is completely absent. Usually the patients will complain of severe abdominal pain that comes on very abruptly. Any type of pain or abdominal distension that comes on during your shift, you would want to report to the physician right away. We're going to monitor them glucose levels. Make sure we're giving analgesics because these patients are in a lot of pain. Pain medication administration is up there with your fluids. And I mean, you're in there, sometimes you're in their room every 2 hours. Every 2 to 3 hours is when they're getting medication. Of course, we want to watch their urine output because we're giving them fluids. They might get, so if sometimes these patients that have pancreatitis will stay in the hospital. It's not uncommon for them to stay in the hospital upwards of 2 weeks because it's quite a process, especially patients that have issues with alcohol. Their exacerbations last a long time. So if they're going to be in the hospital for a while, the IV team might put in a central venous catheter. so that they can get higher fluids quicker. We're going to do cardiac and respiratory monitoring if necessary. Obviously, we're going to be observing and watching for multi-system organ failure. We would see this if they were septic. And then we want to monitor their labs for bleeding. So we want to look at their prothrombin time, their PTINR, their platelets. We don't want the patient to get DIC, which is disseminated intravascular coagulation. We see this with these patients. This is where this happens once the pancreas starts to become necrotic, and it's a very quick release of all these thromboplastic endotoxins, and it causes all of these blood clots, a whole bunch of, like hundreds of blood clots, just to develop all throughout the body. So nursing diagnoses for pancreatitis would be ineffective breathing pattern related to splinting from severe pain, disease process and inflammation, diarrhea related to a decrease in pancreatic secretions, which can cause steatorrhea, which is fat in the stool, deficient fluid volume related to vomiting, decreased fluid intake, fever, diaphoresis, and fluid shifts, acute pain related to irritation and edema of the inflamed pancreas, ineffective health maintenance related to deficient knowledge concerning diet, alcohol use, and medication, acute pain related to irritation and edema of the inflamed pancreas, chronic sorrow related to a chronic illness, and then readiness for enhanced comfort, expresses the desire to enhance their comfort. So that was acute pancreatitis. So chronic pancreatitis is prolonged and progressive inflammation of the pancreas with a gradual destruction of the pancreatic tissue. Usually the main cause of this is alcohol. It can also be hereditary. We see it happen in patients that have hyperparathyroidism, patients who have autoimmune diseases that affect the pancreas. We've seen it with trauma, crush injuries, and then sometimes if they have anatomic abnormalities. So what happens is over time, the pancreas begins to harden, and then those endocrine and exocrine functions are either partly lost or completely lost altogether, and that pancreatic tissue is completely destroyed. It leads to the obstruction of the pancreatic duct and the biliary duct. So risk factors, we said alcohol use. This is the primary cause of chronic pancreatitis. So patients, we also see it, it can develop acutely with where we see an increased use of alcohol. So if vacation, holidays, where people are off for a few days and they drink a lot, graduation, senior weeks, things like that, we will see a big spike in the acute pancreatitis related to alcohol. And then autoimmune diseases, patients that have gallstones, our cystic fibrosis patients, and then there are a lot of other different conditions that can cause chronic pancreatitis. And then we know that it can lead to permanent scarring and damage of the pancreas. So when we do our assessments, what might we see? When we palpate in that upper left quadrant area where our pancreas is, you may feel a very firm mass. It might be noted, it might not be noted. It just depends on what size it is and how inflamed it is and the size of the patient. They're going to have pretty severe persistent pain. So just by the time you give them their pain medicine in another 2 hours, they're asking for it again because it doesn't last long. The pain never really stops. Because they can't eat, they're going to have weight loss. They're going to have a loss of plasma protein from the blood. So you might see peripheral edema, and they might develop ascites in their abdomen. So when they develop ascites, they look like they're pregnant, especially if they're a small person to begin with. It's extremely noticeable. It looks like they swallowed a basketball. And you notice it right away when you see it. You know it's ascites. They're going to have certain digestive disturbances, so they might have vomiting, they might complain of diarrhea, their urine might be dark, they might have a lot of gas. They might get diabetes. Remember, we said that there was a problem with their glucose. They're going to have hyperglycemia, so they might develop diabetes secondary to this. and they can have light colored and foul smelling stools. So some of the diagnostic tests that we would want to do, well, we would want to do CT scans, MRIs, ultrasounds, and an endoscopic retrograde study. This would all be to visualize the pancreas and to determine the functioning status, if there's any necrotic issues, if it's inflamed or red, if there's any bleeding. And then of course, because of the impaired glucose management, we would want to do a glucose tolerance test. So again, rest the pancreas, NPO, no food until the pain subsides. Then when the diet is resumed, it's going to be clear liquid diets to start, then to full liquid. Then when you get to regular food, you're going to start off with bland, high protein, low fat, and no stimulants. So no caffeine at all. Instead of eating 3 big meals a day, we want them to eat very small, frequent meals, easier to digest. No alcohol, no smoking, and we wanted them to limit their stress. There's different drugs we can give. We can give meperidine, we can give narcotics, NSAIDs, and then pancreatic enzyme products. So sometimes they'll take something called Creon. They'll take, some patients take 6 tablets every time they eat, and it helps with developing those pancreatic enzymes to be able to break down the food. So it aids in the digestion of the fats and proteins when you take it with meals. Says that the client can sprinkle the contents of capsules on non-protein foods. I've never seen that done. Usually I just give the capsules and they swallow them, but obviously it can be done. We can also go in and do a stent placement. It can be a partial stent or a total. So partial would be where we go in and take out that blockage and put in a stent so that everything can flow. A total pancreectomy would be total removal of the pancreas. And then we would have to have a pancreatic autotransplantation. So this would be an excision and relocation of the pancreas to a different area if it was salvageable. And that is it for GI1. Do you guys want to take a break here and come back in 15 minutes, or do you want to wait till 8?
We can take a break for the break.
All right, 15 minutes, we will come back, okay? All right, guys, so we are going to start on Elimination GI Part 2. So some of the exemplars we're going to talk about tonight are going to be inflammatory bowel disease. We're going to talk about cholecystitis and then cirrhosis of the liver. These are your objectives. You guys can read over those. So we can help our patients to regulate their bowels a couple different ways. So we can always offer them prune juice if they can tolerate it, if they can drink, they can take stuff by mouth. Warm prune juice is very, very effective. I give it to a lot of my patients and it's very effective. We can always encourage them to include a lot of fiber-rich foods in their diet. They should be eating a lot of whole grains. Choosing fresh fruit and uncooked vegetables is a good way to get all that fiber in your diet. We know that when we have a lot of fiber in our diet, it weighs down our bowel movements, which it bulks them up, makes them heavier, and then peristalsis will keep things flowing so that they can get the bowel movement out. If those things don't work, we can try stool softeners, which help bring water into the stool to make the stool have more water in it so that it bulks it up. And then we can also try a suppository, a non-invasive way. Normal bowel patterns for most people is 3 bowel movements per day, 3 to 3 bowel movements per week. Anywhere in there, it can vary. There is the occasional person that only goes to the bathroom 1 or 2 times a week. And if that's their norm, they've been doing it for 15 years, then it's probably their norm. If they are having consistent bowel movements, that's a sign of a good, healthy GI system. So we remember we always want to help regulate good bowel elimination in our patients who are not moving as much. Maybe, excuse me, maybe they've had a surgery and they're a little bit immobile right now. Maybe they are taking a lot of narcotics, which slows down their GI motility, causes them to become constipated. Maybe they just had a surgery and they were under anesthesia. Everything goes to sleep when they have anesthesia, including their bowels. So we just want to remember how important it is to regulate good bowel elimination habits with our patients. So this is called the Bristol stool chart. And this gives about 7 different types of stool, how you might see it in your patients. So type 1, you would see these little hard pebbles. They're like nuts. They will be very, very hard to pass. Type 2 is the sausage shaped. You can see it does kind of resemble a sausage a little bit, but it has lumps in it. Type 3 is long like a sausage, but with cracks on its surface. Type 4, this is your sausage or snake is what they call it. And it's very smooth and very soft, doesn't have a lot of lines on it. Type 5 would be soft blobs with clear-cut edges. This would usually pass easily when you compare it to type 1, which is hard to pass. Type 6 is fluffy pieces with ragged edges. It's going to be a mushier type of a stool. And then type 7 is entire liquid, very watery, no solid pieces. So sometimes our patients do suffer from constipation, which is a condition in which our stool becomes very dry, very compact, and then it's hard and painful for the patient to pass. If a patient has fewer than 3 bowel movements a week for several weeks, we would diagnose them with constipation. So whenever stool remains in one position in the large intestine, that moisture continues to be absorbed from the residue and it becomes very dry and hard. So pathophysiology and etiology, the peristalsis and distension of the colon help facilitate that signal for our body to help get rid of our stool. Our gastrocolic reflex helps move that stool along by accelerating peristalsis, which makes those waves in the bowels and it pushes the stool out until it finally leaves the body. Reasons why we may become constipated. We could have insufficient dietary fiber in our body, insufficient water intake. They could have a partial or a complete blockage, inactivity, not moving around, opioid use. We also see it with certain systemic disorders, such as multiple sclerosis. So multiple sclerosis is a progressive disease that attacks the peripheral nerves, causing permanent degeneration and destruction of the myelin. So it also affects the body's ability to have that peristalsis and to excrete stool. So these patients get constipated a lot. And then we also see it with diabetes. So what might we see? Assessment findings. We might see scabiela, which is where the stool may feel and look like very small rocks. We may see encopresis, which is where passing liquid stool around an obstructive stool mass. So sometimes your patients will come into the hospital with a diagnosis of an obstruction, a GI blockage. So they come to your floor and they're NPO, but they have diarrhea constantly. And this happened to me when I was a new nurse. And I was like, his constipation has resolved. He has diarrhea. And it wasn't until a couple of days later that I realized that when their stool become so obstructed, actually what's forming around it turns into liquid and it can ooze around the obstruction. So it doesn't mean if they have diarrhea that they don't have this obstruction anymore. It's completely normal to pass diarrhea around that mass. If they have fewer than 3 bowel movements a week for several weeks, we say that they have constipation. They might say that they feel bloated, that their stomach is distended. They would have hypoactive bowel sounds. If they do have a bowel movement, they're going to report that it's hard and dry. And sometimes they also report rectal bleeding because it's so hard for them to pass the stool. And sometimes the stool is large and it can cut the rectum when it's coming out. All right, so diagnostic findings for constipation, we can do examination. So sometimes we can do something called a digital removal, where we go in and we try to manually disimpact the patient ourselves with our hands, with our fingers. Nurses can do that. We can do an abdominal radiography, an x-ray, so this can show if they are full of stool and how constipated they are, if there's any blockages. We could do a barium enema if we think there's some kind of a structural abnormality. They can do anorectal motility studies. This is where they use very thin, flexible catheters that have sensors on them that measure the pressure of the muscles' contractions. So we would do this if we thought that there was an issue with motility. So the body's ability to be able to have, peristaltic activity and to be able to push the stool through the intestines. So what we want to do for medical management is we want to treat the cause of the constipation, and we want to facilitate stool passage by accelerating that peristalsis. So we have a couple different options. We can give the patient an enema. There's all kinds of different types of enemas: saline enemas, soap suds enemas, mineral oil enemas, smog enemas. It just depends on how much stool they have, what condition they're in will determine what type of enema the doctor orders. We can do a laxative, so just an oral laxative for them to take, or even a suppository. The thing about laxatives is that it is really important that we educate them about the risk of being dependent on laxatives. So if we use them all the time, we can overuse them, and then our body won't learn to go on its own. So then you become dependent on them. So that's very important. You guys need to know that. You're going to see that on your exam. We can give them stool softeners, which help bring in the water and bulk it up and soften it. We can modify their diet, so increase their fiber. We can take their fiber to up to 25 grams a day. We want to encourage them not only to drink 6 to 8 glasses of fluid a day alone, just to prevent constipation, but it also when they're taking that fiber. If they're taking a pill, they need to have a lot of fluid with it. We can give fiber supplements, so Docalox and Senecot are a couple brand names that we see in the hospital. For stool softeners, we see Colace. If feasible, we can develop an exercise program, get them moving 3 to 5 days a week, 30 to 45 minutes a day. We know that when they're up and moving, gravity takes effect and keeps everything moving. And then another big thing with educating our patients is sometimes we ignore the urge to defecate. So we feel it, but it's like we don't really have to go right now, so that we hold it. That's the worst thing that you can do. It can cause you to become constipated. The reflex that most people get to have a bowel movement is usually the most active after they eat, usually the first meal of the day. And then we like to encourage our patients to try, if they can, and establish a regular time for a bowel movement every morning, usually best within 30 minutes of a meal, if possible. And then you guys can read the drug table on table 46.1 on page 803, which talks about different medications that we would use for constipation. All right, so for nursing diagnosis, we can have constipation related to immobility or inadequate fluid intake, as evidenced by infrequent passage of stool and abdominal distension. Expected outcome would be that clients will attain a normal pattern of elimination and stools will be soft and easily passed. We can also see acute pain related to rectal distension, difficulty passing stool, or anal tears. And then expected outcomes will be that our client will state reduced or no rectal discomfort. And constipation can be very painful for some patients. All right, So the opposite of constipation, diarrhea. Diarrhea is defined as the frequent passage of larger than normal amounts of liquid or semi-liquid stool, more than 3 bowel movements per day and over 200 grams a day. Loose, watery, unformed stools. Pathophysiology and etiology. So liquid, semi-liquid is what we call diarrhea. It's caused by increased peristalsis, so it moves fecal matter through the GI tract more rapidly than normal. Because it goes so quickly, it causes intestinal cramping and it decreases the time that's available for it to absorb that water. It can cause, can cause dehydration. It can cause electrolyte imbalances, which you guys all know about, and also vitamin deficiency because we're not getting any, our body's not able to absorb any vitamins because it's moving quickly, so quickly through the body. Causes, most common causes are some type of infection, either by a bacterial, some type of bacteria. It could also be a parasitic infection or viral agents. Those are the most common. We also see it if we add fiber to the diet too quickly or too much. Obviously, if we eat something bad, some food poisoning. If we overuse laxatives, we can cause diarrhea. Adverse effects from drug antibiotics. This is a major sign of a side effect of most antibiotics. It causes diarrhea. Things that cause a chronic irritation of the colon. If patients have a lactulose or a fructose intolerance, it can cause diarrhea. And then we see it in our patients that have diverticulitis and ulcerative colitis. So patients that have tenesmus, this is going to be urgency. So they have to go very, very quickly, or they can't hold it. Their stools are, the patients are going to complain that their stools are unformed, frequent, and watery. Sometimes we may see blood and mucus also come with the stool. Patients may complain of a fever depending on what's causing the diarrhea. They may say that they just feel a general state of malaise. And then we know that whenever we have constant diarrhea like that, that the skin around the anus can become excoriated very quickly from wiping and coming in contact with the fecal matter. If a patient suffers from diarrhea for an extended period of time, we know that they're going to be losing volume. So they're going to have deficient fluid volume. They're going to have a decreased skin turgor. Their urine is going to be dark because they're going to be dehydrated. So what kind of diagnostic findings can we do? We can do stool cultures. If we do stool cultures, we're looking for ova and parasites, so things that can cause infection. We can also do an occult blood test, which would look for any type of blood in the stool. So sometimes, especially with food poisoning, you can have diarrhea so bad that eventually it's just all blood. This happened to my daughter when she was like 8 years old. We ate at the Double T Diner and she ate something and she literally had diarrhea. I know it was for like 16 days. We had to go to the hospital multiple times. She had to get IV fluids, and she just had diarrhea so bad that at the last 5 days it was nothing but blood coming out. So you might have to do occult blood testing to test for blood. A proctosigmoidoscopy. We could do this on our patients if we were looking for things in the bowel like inflammation, acute inflammation, chronic inflammation, or anything inside the bowel that would cause a disturbance in that protective mucosal layer in the large intestine. We could do a colonoscopy, which would also check for any type of inflammation or tumors. Sometimes when our patients have a sudden change in bowel habits, so if they all of a sudden had normal bowel habits and then they're constipated, or they always had normal bowel patterns and now they're having diarrhea all the time, or if they're going back and forth between constipation and diarrhea, it can be a sign of colon cancer. So we would want to do a colonoscopy to check for that. We could also do an endoscopy to go down into the stomach to see if there's anything in the stomach, any type of issues with the mucosal layer of the stomach and any kind of inflammation. So medical management is really going to depend on what's causing the diarrhea and how long they've had it. So obviously we can administer anti-diarrheal agents. So the only exception to giving an anti-diarrheal agent is in the hospital setting. If a patient all of a sudden starts having loose stools, we don't want to give them any anti-diarrheal medication until we can rule out that they don't have C. diff. So that would be the first thing. So if your patient starts having loose stools, you would want to call the doctor right away and say, hey, Mrs. Jones had 3 loose stools today. I grabbed a sample. Can we send it off for C. diff? So then we can give her some anti-diarrheal medicine, because we don't want to stop C. diff. We want them to be able to get that out of their body. So those anti-diarrheal agents can be, let's see, Lamodal, Imodium. They can also do a combination product together. It has choline and pectin, which is kaopectate. We would want to do fluid and electrolyte replacement, either oral or intravenously, depending on how dehydrated the patient was. And then we would want to make dietary adjustments. So if they are lactose intolerant and they're just finding that out, or they're having some issue with some other type of a food, we would want to eliminate that food that's causing the diarrhea. If the diarrhea is very severe and prolonged, and if we try to give them oral fluids and food and it causes more episodes of diarrhea, then we have to think about that total parental nutrition, because it's obvious that the diarrhea isn't stopping and they're not getting the proper nutrients. So we have to think of a longer term solution. So nursing diagnoses: diarrhea related to infection, change in diet, gastrointestinal disorders, stress, medication effects, impaction, diarrhea related to an enteric infection as manifested by frequent liquid stools and abdominal cramping, risk for deficient fluid volume related to frequent passage of watery stools and inadequate fluid intake, risk for imbalanced nutrition, less than body requirements related to anorexia and malabsorption, secondary to rapid passage of stool through the GI tract, and then risk for impaired skin integrity related to mechanical and chemical trauma to the rectum. All right, and just, we can always cause diarrhea too when we're trying to fix constipation, just like with our fluids. When we try and fix one problem, we cause another. That happens frequently. All right, so irritable bowel syndrome, also known as IBS, is a functional motility disorder. It causes changes in our bowel function. So you go between chronic diarrhea, constipation, bloating, and or abdominal pain. It's also known as spastic bowel, and it's a functional motility disorder that primarily occurs in the colon. So there's a proximal motility syndrome that affects the colon. The patient is going to experience alternating periods of that constipation. So they'll have a lot of gas, a lot of bloating, a lot of abdominal pain related to the gas that they have, and then diarrhea. It can have mucus or it cannot have mucus. It just depends. It does not cause any inflammation of the bowel or any changes in the bowel tissue, and it does not increase the risk of colorectal cancer. Women are more affected than men. The pathophysiology is fluctuating intestinal motility, usually intensifies with stress, so anxiety, depression. It's not really sure. The etiology is uncertain, but it is thought that certain environmental issues such as certain bacterias, caffeinated beverages, dairy products, immunological issues, there's a genetic component to it. Some hormones and stress can develop cause the development of IBS, and it can influence the course of the disease. And then food intolerance to certain things like dairy and seeds, whole grains, certain foods will cause a worsening of these symptoms. So our patients will present with cramping in their abdominal area, usually pain in the left lower quadrant. They may get nauseous with meals or when they have a bowel movement. They might present with anorexia because they don't want to eat because they're having pain. Or because they're having this abdominal bloating. They can have chronic constipation, chronic diarrhea with or without mucus, or just alternating. So, today's diarrhea, tomorrow it's constipation. No blood will be in these stools normally because the bowel's not inflamed. They will probably have a stable weight, and they are going to have belching and flatulence. So, because they have a lot of intestinal gas. So risk factors are females. If you're under a lot of stress, if you're eating large meals that contain a large amount of fat, if you're having a lot of caffeine intake, or if you're drinking a lot of alcohol. So normally we would want to do radiographic and endoscopic tests because we want to rule out other disorders with similar symptoms. There are a lot of disorders that come along with these symptoms, Crohn's disease, ulcerative colitis, IBS. So we want to rule out other things. We could do, if we did a barium enema and a colonoscopy on the patient, it might show that there are spasms in the colon, might show distension, and we might see mucus. Mucus builds up with IBS. Sometimes, not all the times. So medical and surgical management, we want these patients to have a high fiber diet, so 30 to 40 grams a day, or a bulk forming agent. So that's your Metamucil, your psyllium, and we want them to have a lot of fluid intake. The fiber is going to draw the water in to those constipated stools, and it's going to add bulk to the watery stool. We want to obviously eliminate any common food sources that they know cause discomfort or intestinal gas. So beans, cabbage, things like that. For medications, we can give anticholinergics. So we can give something called Bentyl. It's an antispasmodic. It helps diminish the cramping in the belly. If we give this, we usually want to give it before they eat. We can give those antidiarrheal medications after we send off a stool sample to rule out C. diff. And once it comes back, we have to wait till it actually comes back. And then this can be kind of a debilitating disease for some people because it can affect what they eat. It can affect how they travel sometimes because they have this diarrhea that just comes on so quickly. So they might, our patients may end up with anxiety or even some depression. So we might have to give antidepressant medication. And it also, so it's two purposes. So not just the psychological and the depressant part of it, but it also helps depress and inhibit neuron activity that helps intestinal motility. So we would want to really try to be sure, like when we were talking to our patients about when we're giving them medications, if we give them a medication and we know they have this issue, it might not be because they're depressed. It could just be because it helps with the intestinal motility. So nursing management. So instruct our client to keep a food diary because we want them to, for a couple reasons. We want to record their intake so we can try and figure out if there's something that they're eating that's causing an exacerbation of their symptoms. And then we also want to be able to see what their patterns, their bowel patterns are like. So how many days a week are they having diarrhea? How many days a week are they having constipation? This can help us prevent future exacerbations. We want to educate them about eliminating their alcohol. We want them to stop smoking, and we want them to be able to participate in stress management strategies because we know that stress causes IBS. So we want to encourage them to exercise, regular exercise, 3 to 5 days a week, or also participate with some type of a relaxation technique. And then they can engage in counseling if their depression or their anxiety begins to worsen. So some nursing diagnoses are constipation related to low residue diet or stress, diarrhea related to increased motility of intestines associated with disease process or stress, ineffective health management related to deficient knowledge or powerlessness, chronic pain related to those abdominal spasms and that increased motility, risk for electrolyte imbalance because of the diarrhea, and then readiness for enhanced health management. So the patient expresses a desire to manage illness and prevent onset of symptoms. So Crohn's disease, which is also called regional enteritis, is a chronic inflammatory bowel condition that can occur in any portion of the GI tract, but normally it affects the terminal portion of the ileum. It does begin usually in adolescent or young adulthood. Older adults, well, mid-aged adults, 30 to 50 can also develop it, but predominantly we see it develop in adolescent and younger adults. What happens is the mucosa in the bowel initially thickens and is very edematous and starts to develop ulcers. These ulcers extend through the submucosal layer. Those affected areas then develop hyperemia, which is an increased blood supply to that area. They're going to get more edematous. They're going to develop more ulcers. They might even develop a fistula, which is a hole between two areas. And the common site that we usually see that with this disease is between the perianal and the perilabial. Inflamed areas occur randomly. It's what they call a phenomenon described as skip lesions. This is something that you see just with Crohn's disease. The bowel is described as having a cobblestone appearance of the deep ulcerations that form amid all that edematous tissue in a longitudinal and a transverse manner. So you guys need to know that. So these patients have those skip lesions, which are inflamed areas that occur randomly. And these people that have Crohn's disease, their bowels are described as having a cobblestone appearance. So what causes Crohn's disease? There is definitely a genetic predisposition to it. So patients that are of European or Jewish ancestry are more common to developing this. Patients who smoke are higher risk. And then patients that have allergic or autoimmune responses that can be triggered by diet or infectious microbial antigens. So some assessment findings. So these patients, these symptoms are known for periods of remission and exacerbation. So they could go weeks or months without any flare-ups, any issues at all. And then they'll have like a 5 or a 6 week run of where they have a complete exacerbation and they have all these issues. So they could complain of abdominal pain when they eat. They can have lower right quadrant distension. Their bowel sounds will be very high pitched. They will have tenderness with palpation. They're going to report chronic diarrhea, so 5 loose stools a day with mucus or pus. So for these patients, they are at a very high risk of becoming dehydrated and having potassium issues, right? Electrolyte disturbances because they're having so much diarrhea. These patients will have steatorrhea, which is fat in the stool. So that picture to the right, that's what their stool looks like. It's filled with fat. They might have a fever. If there's an infection there, it's going to cause growth issues in our children and our adolescents. Remember, we said that we usually see this start when the children are younger. They're going to suffer weight loss because they're not eating. They may be malnourished, so their serum albumin levels and their serum protein levels are going to be low. And then they're going to have extraintestinal manifestations. So they can have arthritis, arthralgias, they could develop skin lesions, and then they might have inflammation of the eyes and the liver and the gallbladder. So diagnostic findings, we would want to obviously do a stool analysis on these patients. It would probably come back positive for the steatorrhea. We would want to do an occult blood just to rule out any type of a GI bleed. And then we would want to look for white blood cell counts to monitor, to look for infection. And then it's probably going to be negative for microorganisms or parasites. We will see an elevated white blood cell count. The hematocrit and hemoglobin will be decreased due to anemia from chronic blood loss. Their folic acid and their B12 is going to be decreased. They're going to have an elevated erythrocyte sedimation rate because they are having increased inflammation. So whenever our ESR is elevated, it is a sign of inflammation somewhere in the body. If we do a study with a barium enema, it's going to show inflammation of that large intestine. If they were to go in and do an endoscopic evaluation, they're going to notice that cobblestone appearance. They might even locate a fistula, that perilabial or perianal fistula. Patients with Crohn's disease are very vulnerable to intestinal perforation because the integrity of the bowel wall is very compromised. If they get an intestinal perforation, it's very dangerous. Some patients can die if they have what they call a perf. That's what they call it in the hospital, a perf. We might want to do a biopsy just to see what's going on with the inflammation. We could do an upper GI series with a small bowel also just to follow through and get a good look at everything. We would want to do blood studies because they're losing blood, so we're expecting that they're probably going to have anemia and also some nutritional deficits because of that chronic blood loss. They can also do something called a video capsule endoscopy. For these patients that have severe cases, this is the preferred way to take a look at everything instead of doing an endoscopy, because we don't want to do anything that's going to compromise the integrity of that bowel wall. And if we go in there with that scope, we run the risk of perforating the bowel wall. So they actually swallow this little tiny video. It goes through, it takes about 24 hours to come out. It goes through, they swallow it down. It takes pictures of everything while it's going down, and they excrete it in a bowel movement. Usually about 24 hours after. So medical management, we're going to do a lot of supportive care. So depending on what their symptoms are, how severe their symptoms are, they might have a low residue diet or a high fiber diet. If they're losing a lot of weight and they're not maintaining a good diet, we might have to do TPN. We might have to just do IV therapy to replace the fluid and electrolytes. We may also have to give whole blood if they're suffering from anemia and their hematocrit and hemoglobin are low. We can give antidiarrheals to help stop the diarrhea. After we've sent off a stool culture for C. diff and it's come back negative, we can do antiperistaltics, which we're going to slow down the peristalsis in the intestines. We can give them 5 ASAs, which help decrease the inflammatory response inside the bowel. Corticosteroids obviously help with inflammation. We can do immune modulators, antibiotics if there's an infection, and then supplementary vitamins, because we said that our patients are not getting a lot of nutrients, so they're not being able to absorb vitamins because they're having such, chronic diarrhea. So when the intestine is actually in the inflamed state, the patient is more apt to experience lactose intolerance. So we would want to avoid those lactose-rich foods. We would want to educate the patients to eat high protein, high calories, low fiber foods. We want them to get as much nutrition as possible. Monitor for those electrolyte imbalances, especially potassium. These people might be on a heart monitor, a cardiac monitor. We want to educate the client regarding the use of vitamin supplements and B12 injections, because we might need to do this to replace those vitamins and minerals. So surgical management, this is going to be reserved for severe issues like a bowel perforation, complications. If they have something called short bowel syndrome, Sometimes they need to do an intestinal transplant where they take out all the damaged intestines and transplant it with healthy new intestines that have been donated by somebody else who obviously probably has lost their life. You might have to do an ileostomy, which is where we're going to talk a lot more about this during this lecture. If there's a perforation in the bowel or if there's any fistulas that have formed. So 75% of our patients require surgery within 20 years of symptom onset. 90% require surgery within 30 years. What they have to do is usually it involves going in and removing that inflamed portion of the intestine that does not alter the disease progression or recurrence. Surgical repair is going to be related to the disease. So if there's a perforation or a removal, and then I told you that there is a new research into this intestinal implant. So there are a couple people that have had this. They go in and they take out the diseased portion and they replace it with healthy donated intestine. This is just like any other, they have to take those anti-rejection drugs probably for the rest of their life because this does not belong to them and their body knows it. So the body wants to constantly reject it. So they do have to take those medications that are going to always alter their immune response for the rest of their life. So they're always going to be at risk for developing infections. So nursing diagnosis would be anxiety related to change in health status, ineffective coping related to repeated episodes of diarrhea, imbalanced nutrition, less than body requirements related to diarrhea, altered ability to digest and absorb food, acute pain related to increased peristalsis, risk for deficient fluid volume, risk factor, fluid loss with diarrhea. So this is the difference between ulcerative colitis and Crohn's disease. You can take a look at this. You can see the large intestine, how inflamed it is. And then over here, you can see in the small intestine, the different areas that it affects. And this is in your book if you guys want to read more about that. So ulcerative colitis. So this is chronic inflammation of the mucosal and submucosal layers of the colon and the rectum. The inflammation that develops causes small ulcers to form. Those ulcers produce mucus and pus, and ultimately they start to bleed. Edema and that thickened bowel mucosa can cause partial bowel obstruction because you have that swelling and it gets so thick so the stool can't get through. Intestinal mucosal cell changes can also lead to colon cancer over time or insufficient production of astringent factor, which results in insufficient absorption of vitamin B12. So that's going to cause that pernicious anemia. So these are the patients that are going to be getting those B12 injections or taking those pills. So there is a genetic predisposition. It can be inherited from other family members. It can be caused by infections. It can be caused by an allergy to something. And it also can be an abnormal immune response. So something that our body shouldn't do. The inflammation usually begins in the rectum and it extends proximally. In severe cases, it can involve the entire length of the colon. That's not always the case, but in severe cases, it can happen. There is no healthy tissue between the inflamed areas as we see in Crohn's disease. So in Crohn's disease, you had areas of, let's go back. So in the Crohn's disease, these areas here, these red areas are inflamed, but in between here, you have these healthy areas of your intestine. With ulcerative colitis, you are not going to have that. That whole colon is going to be red right there. You can develop something called toxic megacolon. So this is when the colon dilates and becomes atonic. So it gets really big and there's no motility at all whatsoever. The bowel wall is extremely thin. We know when that happens, it's vulnerable to perforation. If you have perforation, all that stool and all the toxins can leak out into the peritoneum. You can get peritonitis and septicemia. it requires emergency surgical repair. You can die from a perforation. Onset is usually very abrupt. The patient is going to have abdominal distension. They're going to complain of tenderness, and it's going to be firm when you palpate. You're going to hear high-pitched bowel sounds, and then your diarrhea is going to be very, very severe, very watery, and it's going to have a lot of blood, mucus, and pus in it, okay? And you can have up to 15 to 20 liquid stools a day. That is highlighted for a reason. You need to know that. They're going to complain of pain, cramps, and abdominal pain in that left lower quadrant where that colon is. If they're septic, they're going to have fever. If they're losing a lot of blood, they could have anemia. They're having all these severe watery stools, so they're at risk for dehydration, anorexia, weight loss because they're not maintaining any nutrition status because as fast as they're taking it in, it's coming out. And then they're going to obviously be weak and have fatigue. And they're also going to have electrolyte imbalances because of that chronic diarrhea. So for these patients, some diagnostic findings that we can do a barium enema. We can do an endoscopy to go in and see if there's anything going on in the stomach. A proctosigmoidoscopy. We can do biopsies to take to see what's causing the inflammation. If it's some kind of bacteria or if we think it's some type of a cancer, we can take a biopsy to send that off. If we think that the patient has toxic megacolon, that perforation, we would not want to do any of those studies at all. We would want to hold them. So we are going to see that these patients, their hematocrit and hemoglobin are decreased because they're losing blood. Their white blood cell is increased because there could be an infection in there. Their stool can be sent for occult blood, and if they have blood in their stool, it's going to be positive. And then we're going to see that their K, their magnesium, and calcium are all going to be decreased. So our medical and surgical interventions are going to be aimed at achieving remission for this patient. So we want their bowel habits to go back to normal. So their diet is going to be as, as normal as possible, but we're going to modify it because we want to increase their caloric and their nutritional content because they're not getting that because of all their loose stools. If it's so severe and if they have a bowel perf or there's too much inflammation, we have to do bowel rest. Then we're going to think about doing that TPN with lipids to get that high caloric content. They might need blood transfusions due to the anemia and the blood that they've lost through the frequent diarrhea. We would want to give them fluids because they're dehydrated. As far as medications, they're going to be getting those corticosteroids or that prednisone, which is going to decrease the inflammation. So steroids can be a good thing, but it can also be a bad thing. So some educational things that you want to teach your patient about and some things to think about. So anytime you have a patient that is on corticosteroids for a long time, it can lead to what's called adrenal suppression. We're going to talk more about that in metabolism for exam 3. It can also lead to osteoporosis. So in the primary care setting, when you see patients that have a longstanding history of asthma, you will also see that these patients have a higher risk of developing osteoporosis because they've taken corticosteroids, methylprednisone, prednisone for a good portion of their life because of the inflammation they have. It lowers their immune response, so they're at a higher risk of infection. It can cause Cushing's syndrome, and it can also increase our blood glucose levels. So sometimes, depending on what's going on, we might have to put them on insulin in the hospital if their blood glucose levels are too high because of the steroids. So we always want to use corticosteroids in the lowest dose possible to achieve the desired effects, obviously, so that we can minimize those adverse side effects. We always want to teach the client about avoiding these corticosteroids suddenly. You never, ever want to do that. It can cause them to become very angry. It's called roid rage. It's like another kind of a street name for it. It can cause them to become very angry. There's been different cases in the United States where people have stopped taking their steroids suddenly without actually weaning off of them, and they've hurt themselves or other people. And we want to instruct the client to report any kind of evidence of infection, because remember, these steroids can mask infection. So surgical procedures, if we have to do any kind of surgical procedure, we would want to, it's usually done in 2 stages. So this would be like a colostomy on the side, like a bag, or outside of the patient. So the first stage is that they would go in and they would remove the colon and the rectal, they would create what's called a rectal pouch, which is created from a portion of the patient's ileum. The patient's rectal mucosa is removed to create this temporary ileostomy. So they take the rectal mucosa, pull it to the outside of the abdomen, and you have this temporary ileostomy. Then the second stage, the surgeon.
You said the stage 1 is creating a colostomy bag.
Is creating yes, it's bringing the mucosa to the outside, creating that colostomy. Yes, the stoma on the outside of the abdomen. So this allows that area to rest. Then after everything is healed, stage 2, the surgeon goes in and they close that ileostomy and they connect the healthy intestine to the rectum. And now the patient can defecate normally. That's the ideal. That's what we want to see happen. So that colostomy is just a temporary measure until everything can heal. So nurse management, we are going to instruct the client, obviously, to seek emergency care if we think that the patient has a bowel obstruction or a perforation. So that's fever, severe abdominal pain, and vomiting. So that fever is going to come with that perforation when all of the contents of the bowels, which is just stool, gets into the peritoneum, and they can get into the bloodstream. So we're going to be really sick and septic. Abdominal pain, vomiting. We want to instruct clients who have an extreme or long exacerbations that they're going to have an NPO status and that they might have to have TPN, because we need to be able to promote bowel rest and give them the adequate nutrition that they need, that they're not getting because of these extreme or long exacerbations that they're having. So nursing diagnoses, we would see diarrhea related to inflammation in the colon, deficient fluid volume related to frequent stools, acute pain related to inflammation in the colon, and then readiness for enhanced knowledge, so expressing an interest in learning, so learning how to manage their disease. All right, so now we're going to talk a little bit about the liver. So our liver has a couple different functions in our body. It metabolizes our glucose, our proteins, and our fats. It also metabolizes certain drugs that come in, certain chemicals, bacteria, and also foreign elements in the body. It works to convert glycogen to gluconeogenesis. You guys probably remember that from biology and the Krebs cycle. It converts ammonia. Ammonia is a byproduct of gluconeogenesis. It turns that ammonia into urea, so it can be excreted. It metabolizes proteins and fats. It helps regulate our blood glucose. It stores certain vitamins, so vitamin A, B12, D, and B complex vitamins, also iron and copper. It forms and it excretes bile and bilirubin. You know, bilirubin is what gives us that jaundice color if we're not excreting it, and it builds up in our system. It synthesizes certain factors in the body that we need in order to have our blood coagulate. It synthesizes factors that are, well, that's just a repeat. That shouldn't be there. So our prothrombin, our fibrinogen, those are all things that work together in a big cascade to help our blood coagulate. And then remember, we learned in Nursing 103 that our drug availability, how much drug a patient takes in after they take their medicine, is controlled by the liver's first pass effect. So when a drug is absorbed by the small intestine, it travels to the liver, where a portion of that drug is going to be metabolized. So then as a result, a less active amount of that drug is circulated to our tissues and available to our patients. All right. All right, so cirrhosis of the liver. Cirrhosis is a chronic degenerative liver disorder that's caused by cellular damage to the liver. It is a permanent scarring of the liver that's usually caused by chronic inflammation. It's where the normal liver tissue is going to be replaced with fibrotic tissue that has no function at all whatsoever, and it causes irreversible damage to the liver cells. So what consequences are we going to see in our body once our liver cells are damaged? Well, it's going to alter and affect the way we are able to digest and metabolize things. It's going to cause issues with our body being able to properly coagulate. It's going to cause fluid and electrolyte imbalances, and it's going to also cause impaired ability to metabolize hormones and detoxify chemicals. So if we go back to all the things that the liver does and we look at these, and if we know that cirrhosis of the liver causes an impairment in all of these, so you can pretty much figure out what's going to happen in the body if these things are not working. Okay. So this is actually, did I read all this? I did not. Okay, so what happens is bile starts to drain into the intestines, and our patients start to experience fat malabsorption, and they are not able to absorb our fat-soluble vitamins, which we talked about in nutrition, are A, D, E, and K. Over time, the patient is going to experience portal hypertension. So they're going to also develop esophageal varices inside the esophagus. If they rupture, they can cause bleeding. The patient can actually bleed to death. We're going to see ascites in the abdomen. It's going to be a big influx of all this fluid. We're going to talk a little bit more about what causes these. We're going to see hepatic encephalopathy, which is where ammonia levels build up in the body and our patients become very confused. These are all complications of advanced cirrhosis. So this is what a normal liver looks like here. Both of the lobes of the liver here are completely combined. If you see this liver over here, it's completely separated. So the liver with cirrhosis takes on what they call a hobnail appearance. And then it just regenerates with bad tissue and scar tissue. And it actually looks like it's in two separate pieces there. So there are three types of cirrhosis that you may see. Alcoholic cirrhosis, post-necrotic cirrhosis, and biliary cirrhosis. So alcoholic cirrhosis is the most common type of cirrhosis that you will see. It is associated with chronic alcohol abuse and poor nutrition. You can also see it after poisoning with certain chemicals such as carbon tetrachloride, which I have no idea what that is. It's some type of cleaning agent. Or if you have an ingestion, a huge ingestion of hepatotoxic drugs, so if acetaminophen. So if someone tries to overdose on Tylenol, you could see it develop into this. Usually alcoholic cirrhosis of the liver develops over a long period of time, like 30 years. And it is characterized by those liver cells are going to become necrotic, and they are eventually replaced over time by scar tissue, and the liver is not able to function anymore. Post-necrotic cirrhosis is going to be caused by infections. So this is your viral hepatitis, certain types of metabolic liver disease, certain medications, or toxins. These post-necrotic cirrhosis causes broad bands of scar tissue to form in the liver, and then that scar tissue causes cellular destruction. We see this associated with chronic hepatitis C. So this is actually the second leading cause of cirrhosis. So alcoholism is the first, chronic alcohol intake, and hepatitis C is the second leading cause of cirrhosis. And then we have biliary cirrhosis, which is caused by chronic biliary obstruction and infection. And sometimes it can be caused by an autoimmune disease. Scars build up around the bile ducts in the liver. It obstructs completely or partially the flow of bile into that small intestine, so then it builds up. So risk factors for cirrhosis. So we said that alcohol abuse, chronic viral hepatitis, it can be B, C, or D. Autoimmune hepatitis, this is where the body destructs the liver cells by the immune system. We can have it caused by damage to the liver from different medications, substances, toxins, and infections. And then we have something called cardiac cirrhosis, which comes from severe right heart failure, which causes necrosis and fibrosis to the liver due to that lack of blood flow. Because remember, if we have right-sided heart failure, everything tends to pull down to the lower extremities and we're not getting good blood flow to that area. So things become necrotic. So we actually have two types of clinical manifestations or findings. We have compensated clinical findings, and then we have decompensated clinical findings. So compensated clinical findings happen earlier, and they might not be linked to actual cirrhosis. They can be commonly misconstrued as being like other issues in the body, where the decompensated ones are directly related to the cirrhosis, and 9 times out of 10, they know that that's what's causing it. So your compensated clinical manifestations are going to be intermittent mild fevers. You might see vascular spider veins on your legs. Reddened palms, we call that palmar erythema. We might see cutaneous spider angiomata, which is like little tiny spider-like blood vessels. You can get them in the arms or the legs. Unexplained epistaxis, ankle edema, vague morning indigestion in the morning when you wake up, flatulent dyspepsia. They might complain of abdominal pain, a firm enlarged liver. This is going to cause your abdomen to be extended. Distended, you'll actually be able to palpate the liver because it's enlarged. And splenomegaly, which is when your spleen becomes enlarged. So all these things could be attributed to something else. So they're not very concrete. Now your decompensated clinical findings. So you're going to see ascites. So that's where the abdominal, the abdomen is going to be extremely swollen because you're going to have liver dysfunction and that portal obstruction. So that fluid is going to build up in the abdomen. Your bilirubin is going to be building up in the body. So you're going to see jaundice. You're going to see it on your skin, your mucous membranes, and in the sclera of your eyes. Patients are going to be weak. They're going to have muscle wasting, weight loss. They're not going to be able to hold on to any of their vitamins. They're not taking in any nutrients. They have issues with absorption. So they might have a continuous mild fever. You might see clubbing of the fingers. They might develop something called purpura, which is, we see this because of the decreased platelet count that they have in the body. They might complain of chronic fatigue. Again, no nutrition. They're not absorbing any nutrients, so they're exhausted. They're anorexic because they're not eating. They might be complaining of that chronic dyspepsia, which is indigestion. Nausea. So the indigestion and the nausea can also come from all that swelling in the abdominal region. It gets swollen and it puts pressure on the stomach, makes you nauseated, causes that indigestion feeling. Clay-colored stools, they might have diarrhea, spontaneous bruising, because we remember our ability for our body to produce blood coagulation the correct way is now compromised. They might have epistaxis, they might have bleeding from the gums, hypotension. Certain parts of the body will have sparse body hair, like the legs, certain areas of the legs. They might have white nails, gonadal atrophy in men. They might have cognitive changes, or confusion. So what happens is when ammonia builds up in the body and all those waste products, they build up in the blood, and they cross over into the brain because the liver is not able to get rid of them. So once they cross over into the brain, then that's when you see those cognitive changes. So they don't know who they are, they get confused easily, they have difficulty thinking, forming sentences. They could also be constipated, might see tea-colored urine. Shortness of breath is a pretty common finding because of that ascites that they have in the abdomen that pushes up against their diaphragm, makes it difficult for them to breathe. And then they might also see petechiae, which is those round, pinpoint, reddish, pinkish, purplish bruises on the body. We also are probably going to see jaundice because they're going to have abnormally high amounts of pigment, bilirubin in the blood because those ducts are obstructed and the bilirubin's building up. It's defined as a greenish yellowish discoloration of the tissue. Visibly, we can note it on the skin and the sclera and our oral mucous membranes. Our total bilirubin concentration should be between 0.2 to 1.3. Jaundice usually becomes visible if the patient's bilirubin level exceeds 2.5. So this is going to be a level that you're going to be checking constantly when this patient is in the hospital. You're going to be looking at their liver functions, so their AST, their ALT, their bilirubin. Bilirubin levels can increase in the body when there's an excessive destruction of our red blood cell count. So different things in our body can cause destructions of red blood cells. And when our liver cannot excrete bilirubin in a normal fashion and it builds up. So they may also complain of pruritus, which is really itchy skin, and that is a very common finding. These patients are very, very itchy. They're always asking for moisturizing cream, even pharmaceutical types of moisture cream prescribed by the doctor to really help put some moisture in their skin because it's very dry, and it comes from those bile salts accumulating in the body. They're going to have that ascites, which is the bloating or swelling due to that buildup of the fluid in the abdomen. Their sacral area could be swollen, their legs. They might have gastroesophageal bleeding. So inside the esophagus, they're going to have these enlarged veins. We call them esophageal varices. They develop, they can burst. When they burst, it can cause vomiting and passing of blood in the bowel movements. They can vomit blood and have it in their stool, obviously. So when they bust, it's just they're gonna have this constant bleeding. Or they can have portal hypertensive gastropathy, which is bleeding of the gastric mucosa. So all the pressure is building up. All these things are enlarging, especially these varices, and patients actually can bleed to death. They can have so much blood loss that they bleed from one of these varices. We're going to see splenomegaly. So this is an increase in our spleen, in the size of our spleen, which is going to be caused from the backup of the blood into the spleen. Because the blood backs up into the spleen, it's going to hold on to all the red blood cell counts. So it's going to cause thrombocytopenia and platelet destruction. So these patients, when you run their platelets, they're going to have low platelet counts and they're going to have a low H&H because the spleen is holding on to all the blood. Like we said, we're going to see that palmar erythema. This is the redness in the palms. They're also going to be very warm. We're going to see those spider angiomas. They're red lesions, vascular. In nature, they branch off. You might see them on the nose, the cheeks, the upper thorax, the shoulders. Asterixis, which is a liver flapping tremor. So it's a coarse tremor that's characterized by rapid, non-rhythmic extension and flexion of the wrists and fingers. I've actually never ever seen that as a nurse, but it does go over it in your book if you want to take a look at that. And you guys should know what that is. And then there's something called fetor hepaticus. This is liver breath. So these patients have very bad breath. Sometimes it can have a very fruity smell, and then it can also have a very musty odor. So you guys should take a look at page 833, box 47.2, goes over all those clinical manifestations of cirrhosis. So we would want to do a liver biopsy to identify, to actually verify that they do have the cirrhosis, but then we also want to know how far it's progressed and what is the extent of it. This is the most conclusive test for determining if a patient has cirrhosis of the liver. Usually it's obtained percutaneously, where they just go in with a little needle, or they can do a surgical incision where they open up the abdomen. It's very often seen that we will give our patients, before they have this procedure done, in a quick bag of vitamin K, or give them a bag of platelets before that biopsy, because we want to reduce the risk of bleeding complications. We said they had issues with their blood anyway. Their hematocrit is low, their platelets are low. So if we have this procedure and they go in and they start bleeding, they don't have anything to keep them from bleeding out, because they're not going to be able to coagulate properly. We can do abdominal x-rays or a CT scan. This would be used to visualize if the liver was enlarged, if the spleen was enlarged, or if they had ascites. It would show, if they had ascites, it would just show all the fluid in the abdomen. We could use an MRI if we thought there were cancerous lesions or masses on the liver, and it could determine if those lesions were malignant or benign. We could do a radioisotope liver scan to demonstrate the liver's enlarged size, any issues with nodules, and any kind of issues that would cause a disruption in blood flow. And then we could always use an ultrasound that can help also detect if the fluid is ascites, looking for that swollen, enlarged liver and spleen. It can also identify any biliary stones or biliary obstruction. So laboratory tests, like I said, we're going to be looking at all those liver enzymes, ALT, AST, ALP. These are all going to be elevated due to that inflammatory response and that biliary obstruction. We're going to be looking at those bilirubin levels. They're going to be elevated because the ability can't excrete the bilirubin. We're going to look at protein and albumin. These are going to be decreased because of hepatic synthesis. Our red blood cells, our hemoglobin, hematocrit, and our platelet counts are all going to be decreased, because remember, the spleen is holding on to all the blood. Thrombopoietin is going to be produced in the liver, so that is a major factor to our blood clotting. So if our liver's not functioning properly, we're not making what we need for our body to clot properly. And then, like we said, that spleen enlargement causes more platelets to be retained in the spleen and less for our body to use if we need them. So patients that have cirrhosis can develop something called portal hypertension. So this is where blood in the body starts to back up into what they call the portal system. So the portal system is those gastric veins from your stomach, it's the mesenteric vein from your intestines, and it's the splenic vein from the spleen and the pancreas. And then the portal vein is also there from the liver. So blood backs up in that portal system. All the veins drain into and through the liver and out of the hepatic veins into the inferior vena cava. That's usually what happens. They drain, they go through the liver, and they go out through the hepatic veins, and they go back to the vena cava. Well, in portal hypertension, that doesn't happen. All the blood backs up. It causes congestion and increased fluid pressure in that portal system. So these patients are going to present with GI bleeding. So they're going to be vomiting blood. They're going to have black tarry stools or bloody stools. If it's an old bleed, they're going to be black and tarry. If it's a new fresh bleed, they're going to be bloody. They're going to have ascites in their abdomen. They're going to have encephalopathy from the buildup of all the toxins in the body, and they are going to have decreased platelets. Treatment, we want to reduce that fluid accumulation and that venous pressure in that portal system. So we are going to make sure that our patients are on a sodium restriction. We're going to restrict their sodium through their diet. So they're only going to be allowed to have a certain milligram of salt per day. We will also probably give Lasix or aldactone, because we want to get all that excess fluid out. And then we might have to go in and do a surgical or a non-surgical shunt to reroute all that fluid that is built up. These patients can also develop something called esophageal varices. We've been talking about this. This is another complication of cirrhosis. So this is where our esophageal veins bulge and they begin to dilate. They get bigger and they become more fragile and they can easily rupture and start to bleed. This can be caused from the portal hypertension. These are the esophageal varices are vulnerable to bleeding because the veins lie superficially in the mucosa and they can be traumatized by rough food or any kind of chemical irritation. So if you're not chewing your food properly, or if you're taking big bites, it can cause, or if you're eating like corn chips, things that are hard, it can cause damage. It can be a chronic, so it could just be just a mild form, and chronic, it can happen constantly, or it can happen very rapidly and be a massive bleed and the patient could actually bleed out. Obviously, massive onset is going to be life-threatening emergency that's going to require an immediate surgical intervention. Once active bleeding begins, then the patient starts having clotting disorders because they're losing so much blood. So in order to diagnose these, we could do a barium swallow, we could do an esophagoscopy, a CT scan. We could also do an MRI. An MRI would be more detailed. So how do we treat these? We can do something called sclerotherapy, a variceal band ligation, or a Sengstatin Blakemore tube. So I actually couldn't fit it on here, so I actually put it down here. So if they do sclerotherapy, it's an injection. So the physician passes an endoscopy tube orally through the mouth to locate the varice. They put a thin needle through the endoscopy into that actual varice, and they inject a sclerosing agent. It causes that varice to solidify and it stops the blood circulation to that area, so it stops bleeding. If they do that variceal banding, the physician would use a device that has very small rubber bands on the end of that endoscope. They would find the varice, they would place the rubber band over it. That band obviously is going to restrict the blood flow to that area. After a couple days, that band disintegrates and sloughs off. Because if the patient has portal hypertension, this is going to form again. It's not a complete fix. So they might have to repeat the sclerotherapy or the banding procedures regularly if that portal hypertension is a chronic issue. And then that Sengstatin Blakemore tube, that's actually a balloon tamponade that they use to go in. So if surgical option, if they can't go in and do an endoscopy right away, they can use that. They blow up a small balloon and it kind of puts pressure on that varice and keeps the blood from flowing for us. It's not a complete permanent fix. It's just until the patient can be put in a situation where they can have the surgery. So obviously we would want to do IV fluids to replace the volume that they're losing. We're going to want to replace blood products, so red blood cells, packed red blood cells, platelets, albumin even. We can give IV octreotide, which is also called sandostatin. This drug reduces the pressure in the portal venous system. This is a good medication. We also want to take measures to prevent bleeding. So we're going to treat the portal hypertension. So we're going to give the IV octreotide. We want to encourage a soft diet, so nothing that's going to agitate that esophageal area. Stool softeners so that they don't have any problems with constipation. We want to encourage the patient not to take any aspirin or alcohol. And then if they do have a cough, we want to give them antitussives to reduce that cough because we don't want anything that's going to cause trauma in the esophageal area, and coughing can do that. So you guys need to know about that IV octreotide. You're going to see that on your exam. So ascites is another complication of cirrhosis of the liver. We've been talking about this a little bit. This is when fluid collects in the peritoneal cavity. It is visible as an extensive and massive abdominal swelling. That's an appropriate picture. These patients look like they are 8 or 9 months pregnant. It causes hepatorenal syndrome, which is increased pressure in that portal system, which is going to force all of those proteins into the perineal cavity. How we fix this is we go in and we do a abdominal paracentesis. So these patients, especially patients that have issues with alcohol, they have these quite frequently. This is the only way to control the ascites because it just keeps coming back and it keeps coming back. So we go in, we do this abdominal paracentesis because we want to go in and remove that acidic fluid. We want to decrease the discomfort that they have because these patients are extremely uncomfortable. They have issues with their bleeding. They have issues sleeping because they have issues breathing. They always feel like something's sitting on their lungs. They don't have an appetite really because their stomach is pushed in because of all the ascites. So they're very uncomfortable. And when they come back from having this done, they're like new people. They report that they're like 150% better. So what they do is they take, they don't have to have general anesthesia for this. It's local. They go in with usually an ultrasound. It's an ultrasound guided needle. They go in through the abdominal wall and they grab that fluid and they drain it. Usually they take up to 5 or 6 liters of fluid over a period of 90 minutes. I've seen as high as 11 liters come off a patient before. This was a patient who had had a liver transplant that was failing and he literally had 11 liters of fluid. I mean, you know how big one bag of fluid is, of an IV bag, 1 liter bag. That's humongous. So imagine having 5 or 6 of them or 11 inside your abdomen, how uncomfortable that would be. So we can take that amount of fluid out over a certain amount of time, 60 to 90 minutes. We can also use IV albumin at the same time to help pull some of that fluid back into the vascular space. Obviously, if we do that, we run the risk of causing fluid overload. So we might have to do diuretic therapy, right, to take care of that circulatory volume if it becomes excessive. And then these patients, you're going to want to monitor their blood pressure and their urine output pretty frequently because of these extreme fluid shifts. So as they are pulling this fluid off in the body, they're constantly doing their blood pressure. I don't know how often they do it, but I feel like it's almost every 15 or 20 minutes during the procedure, because even though they might need to take off 5 or 6 liters, if the patient can't tolerate that sudden change in fluid shift, you can't take it all off at the time. So you would have to stop if they were having blood pressure issues and then come back the next day and have some more taken off. So monitor that blood pressure. And then when they come back to the room too, because that fluid shift change can occur over a couple hours, make sure they have good urine output. Again, those additional treatments we can see is that we're going to restrict their diet. We don't want them to have a lot of sodium. Sodium holds onto water. We don't want them to hold onto water. And then we're going to use aldactone. So aldactone is the medication that we use because it specifically antagonizes the hormone aldosterone. It reverses the effects of aldosterone and causes the excretion of sodium and water. And it causes the retention of potassium and the reduction of acidic fluid. So that's the drug of choice usually for this patient that has ascites. They can also develop something called hepatic encephalopathy. We've talked a little bit about that. This is the central nervous system manifestations of liver failure that can lead to coma and death. So this is related to those increased ammonia levels that we talked about because the body can't excrete them. So the liver normally detoxifies ammonia by converting it to urea, which then the kidneys get rid of in our urine. But that doesn't happen with cirrhosis of the liver. So our liver starts to fail. It can no longer break down that ammonia. The ammonia starts to accumulate in the blood. The ammonia then crosses the blood-brain barrier. It starts to enter our brain cells. It interferes with our brain's metabolism, our cell membrane pump mechanisms, and our neurotransmission. So then we're going to see these CNS effects. So they're going to be disoriented, they're going to be confused, you're going to see personality changes, asterixis, which is that flapping tremor. They're going to have positive Babinski reflexes, and they might have a sulfurous breath smell to their breath. So this is actually, it's really sad to see this. I've seen this in a couple patients, like patients that were young, like 40, 50 years old, that didn't know who they were, didn't know who their husbands were, didn't know who their children were. And sometimes this can be reversible in the early stages. Once we control the ammonia, we can get them feeling a little bit better, but eventually, as it progresses, it just becomes, it's less and less of a chance that they're going to be able to recover this, and they're going to stay in this state. And that's when it's actually just going to lead to coma and death. So what treatment are we going to do? We're going to eliminate a lot of protein in their diet. We are going to remove any residual protein. By the blood, if the client had any kind of recent hemorrhage. We are going to deplete their intestinal microorganisms. So we're going to give them laxatives and enema therapy. We're going to give antibiotics to destroy intestinal microorganisms. Sometimes this happens, it can cause when we're decreasing the ammonia production. It serves two purposes. I said that wrong. Antibiotics to destroy the intestinal microorganisms, and as an added effect, it helps decrease the ammonia production, which will decrease the confusion that they have. And then we give something called lactulose. So most of these patients that have cirrhosis of the liver, 90% of them are on lactulose. This reduces the serum ammonia concentration, and it allows them to have multiple bowel movements per day. Usually they have a certain number of, usually this medication comes with a criteria. So if the patient is producing 5 to 6 bowel movements during the day, then they only give 3 of them. If they're only producing 1 to 2 bowel movements a day, then they increase and give them more at night. It's usually on some type of a scale. So that's the only way to get rid of the ammonia and to get the CNS effects to return to normal, is to poop this ammonia out. So they're constantly monitoring their ammonia levels. The prognosis for clients with hepatic encephalopathy is very grim. Only a few will survive without a liver transplant. And clients who do survive face a very prolonged rehabilitation. So there is no specific cure. We just want to do things that will prevent further deterioration. So we're going to give replacements of vitamins. So our vitamins B, vitamin C, K, and our iron. We're going to give nutritional supplements, no alcohol. For advanced liver disease, we're going to restrict their protein intake because they can't break it down. We're going to administer that lactulose, which is going to promote the excretion of pneumonia from the body by stool. It also acts as an osmotic agent. It draws water into the bowel and causes diarrhea. We're going to give antacids or histamine H2 receptor antagonists. These are going to help reduce their gastric disturbances and decrease that potential for a GI bleed. So it's more of a protector. We're going to give potassium sparing diuretics to treat the ascites. We might give colostramine, which is bile salts, which is going to help relieve pruritus. We're going to give platelet transfusions because we want to correct that thrombocytopenia, which is the low platelets. We can give something called Actigal, which promotes bile flow from the liver so it's not building up. And we want to regulate their low sodium intake. So we know that water retention can lead to edema. It can cause more circulatory congestion than they already have with that portal hypertension, and it can cause heart failure. And then if necessary, we also have to eliminate restrict their fluid intake. So for nursing, we want to monitor their vital signs. We want to monitor their pain level, see how uncomfortable they are. Do they require any oxygen because they're having issues breathing because of the ascites? We want to do daily weights on these patients to determine if their weight is coming down, if we're removing fluid. So strict I's and O's, we want to measure their abdominal girth over the largest part of their abdomen every day. We're going to monitor that respiratory status, monitor oxygen saturation levels, and monitor for any distress. These patients may have to sit in a chair or elevate their head of the bed to 30 or even 90 degrees to sleep and to be comfortable. We're going to monitor their nutritional status. So high carbohydrate, high protein, unless they are having the, what did we say back here? If they were having hepatic encephalopathy. So if they're not having that, then we would have a high protein, moderate fat, low sodium diet. We would want to give lots of vitamin supplementation. So these patients usually are getting a lot of PO vitamins and what we call a banana bag, which is like a liter bag, just it's usually yellow and it's just full of vitamins. They need it because they can't absorb anything. So thiamine, folate, multivitamins. We want to encourage them to eat small, more frequent meals. They need that semi-solid liquid meals, remember, because we don't want to do anything that's going to cause any problems with the esophagus. We're going to monitor that skin integrity, monitor closely for any skin breakdown. These patients that are taking the lactulose are going to be having very frequent bowel movements, so their skin can get raw pretty quickly. We also said that some of these patients have really itchy skin, so we can encourage them to take a cool shower, use a cool washcloth on their arm, apply lots of lotion to help decrease the itching. We're going to be concerned with their fluid balance in either direction. So we're going to be monitoring for fluid volume excess or if they're deficient, if they're losing too much fluid. So strict I's and O's, daily weights, assess the ascites, and if they have any peripheral edema. We want to monitor their response to any drug therapy that we're giving them. So if we're giving them lactulose to bring down the ammonia level, we're going to be monitoring those labs, the ammonia levels, to see if they are coming down. We're going to want to note if there's any change in their mental status. Is it getting worse? Is it getting better? And then any signs of a GI bleed. So if they're vomiting blood, if they have bright red blood in their stool, or any dark stools. And these patients, if they have cirrhosis of the liver, it could be caused by alcohol. So we want to make sure that they're not going through alcohol withdrawal. So we're going to be monitoring for increased blood pressure and pulse and increased temperature, tremors, auditory hallucinations, visual hallucinations, sweating, all those things. And then client teaching. So we want to teach them about the disorder that they have, if it's from hepatitis C or if it's from alcohol. We want to encourage the use of support groups, so Alcoholics Anonymous. We want to encourage them to participate in any treatment regimen, so taking their lactulose as prescribed to keep their ammonia levels down, fluid restrictions, and then if anybody's coming to visit them at home, they might require some type of home care, some type of nursing home care, depending on what's going on. So this is the 12 steps. This is the Alcoholics Anonymous. This is the 12 steps that they follow. They actually work these steps. They go through a process. There's no certain time period to which they have to go through these steps, but they work these steps, and some of them rework these steps over and over in their life until they learn different things about themselves, and that these steps help them to live a better life and make changes in their life, and hopefully be abstinent from alcohol or drugs. NA also has a 12-step program as well. So nursing diagnoses that we might see for cirrhosis. So chronic confusion related to chronic organic disorder with increased ammonia levels, related to substance abuse, defense, coping, related to inability to accept responsibility to stop substance abuse, fatigue, related to malnutrition, ineffective health maintenance related to deficient knowledge regarding correlation between lifestyle habits and disease process, imbalanced nutrition, less than body requirements related to loss, nausea, vomiting of appetite, risk for bleeding, risk factors, impaired blood coagulation, bleeding from portal hypertension, and risk for injury, risk factors, substance intoxication, and potential delirium tremens. All right, so cholecystitis is another exemplar we're going to talk about. This is inflammation of the gallbladder wall. Most often, this inflammation is caused by gallstones that obstruct the cystic and or the common bile duct. Normally, bile duct flows from the gallbladder to the duodenum. This causes bile to back up and the gallbladder becomes inflamed. Bile, we use bile in our body to help digest our fats, and it is produced in the liver and we store it in the gallbladder. Cholecystitis can either be acute, so it can come on very abruptly, or it can be chronic. Cholecystitis can obstruct the pancreatic duct and also cause pancreatitis. And it can also cause the gallbladder to rupture, resulting in secondary peritonitis. And it can also cause the patient to become septic, especially if it's infected. Oops. Okay, so risk factors for developing cholecystitis. Whoops. It is more common in females. It is believed that it is due to the fact that some females take hormone therapy and they use contraceptives which have hormones in it. It is something that we see in patients who have a very high fat diet. We see a lot of acute onset when patients, or an exacerbation when we have, when they eat something that's very high in fat, it kind of triggers it. It can be caused in patients who are obese because we have an impaired ability for our body to metabolize our fat, and we also have high cholesterol. It can have a genetic predisposition, which is absolutely true. My aunt had it, my mother had it, I had it, both my daughters have it, my grandmother had it, we've all had our gallbladder out. So definitely a predisposition genetically. Older adults, we see this in older adults because there's decreased contractility. These patients are more likely to develop gallstones. We see it in patients with type 2 diabetes, patients who have cystic fibrosis. Patients who are on low-calorie liquid protein diets are more susceptible to developing gallstones. Patients who have a rapid weight loss. When patients do this, it causes an increase in their cholesterol levels sometimes, which causes the development of gallstones. And then we also see it in Native American or Mexican people. So assessment findings. So symptoms become acute when a stone will become lodged in some kind of a duct and block that bile flow from the gallbladder. So that's when it becomes acute. The discomfort that the patient feels is going to be because the development of inflammation, and there's going to be spasms in that area. Their patient is going to have digestion problems from reduced or absent bile. They might have swelling in that area, and then the gallbladder can actually become necrotic if it manifests and is left untreated. So the patient might complain of belching. They might complain of nausea and vomiting. They will complain of this right upper quadrant pain. For women, they will say that it's immediately under their breast. 99 times out of 10, that's where they say it is. They'll say it's right under my boob. It often radiates from that area up to the right shoulder, and it can also cause right back pain as well. They'll say it goes up the right shoulder, or that it goes up the right shoulder and into the back. And then they'll get cramps or these pains after eating a very high fat meal. So When it's acute, they can have a fever. Fever would be because that gallbladder is necrotic or it's filled with infection. They will be vomiting, abdominal tenderness over that area of the liver. They're going to have that pain that radiates to the back and the right shoulder. Depending on how advanced it is, they could be slightly jaundice. So again, you're going to be looking at the skin, the oral mucous membranes, and the sclera. Their urine is going to be a very dark black, and their stool is going to be a light color. So when we look at laboratory tests, we're going to see an increased white blood cell count because it's going to be indicative of an infection in the body. That serum bilirubin is going to be increased if that bile duct is obstructed. So the bilirubin keeps building up. That's going to cause the jaundice as well. And then we're also going to look at amylase and lipase. And if there's some kind of pancreatic involvement, those levels are going to be elevated as well. So diagnostic findings, we can do a cholecystography, which is where they go in and they do a gallbladder imaging. We can do a CT scan. We can do an ultrasound. Ultrasound will visualize the gallstones and a dilated common bile duct. We can do radionuclide imaging. We can do a PTCA, which is a percutaneous transhepatic cholangiography. If we do this, this is going to be able to differentiate between jaundice that's caused by some type of liver disease or jaundice that's caused by just the gallbladder disease. We can also do an ERCP, which is an endoscopic retrograde cholangiopancreatography. That's like a whole mouthful, so ERCP. This will visualize the esophagus through an endoscopy that is then inserted into the common bile duct from the duodenum. We could also do an MRCP. This combines an oral contrast and an IV contrast, which causes the dye to go through all the areas. Then they take pictures and to determine where the dye goes and if there's any type of blockage or if the patient has cholecystitis. So I feel like in the hospital, usually if a patient has an ultrasound and they see gallstones, they automatically say that the patient has cholecystitis. And if it's not an acute and they're not having a lot of pain right now, they do it on an outpatient setting. If there's fever and a white blood cell count and infection, they'll do it right then and there. Some places will also have the patient have a HIDA scan, which we do talk about in here somewhere. Some doctors feel like when the patient has a HIDA scan, if that's positive, that's completely indicative of gallstones, and they will go off of that. So it's really a doctor's preference which method of diagnosing gallstones they choose to use. Usually it's the HIDA scan or the ultrasound. And then if they need surgery, we look at their symptoms and their labs. So if they're having a lot of vomiting and they're not able to hold anything down, they're going to get an NG tube. We want to decompress their stomach, pull out all the bile, and keep the patient comfortable. Obviously, they're going to be NPO. Nothing by mouth. We're going to give them antibiotics. We could do it if we have an elevated white blood cell count, or we could do it prophylactically if they're getting ready to go into surgery. If the gallbladder is inflamed and it has infection in it, they will have to have antibiotics for a certain number of days until that infection resolves and the inflammation goes down, because there's always a chance that it can rupture during surgery and then that infection can spread throughout the peritoneum. So antibiotics for a couple different ways. Obviously, we're going to give them analgesics because these people are in a lot of pain. Morphine or hydromorphone, which is also dilaudid. They're going to be getting IV fluids if they're NPO, obviously. If they can eat, they're going to have a low-fat diet. We can do something called lithotripsy, which is where they go in and they break up, they deliver shock waves to the patient, and we can help if there's just maybe 1 or 2 gallstones and there's nothing else going on with the patient. We can try to just break them up and then they can pass through the duct and then the patient's fine. if you want to get more information about that ERCP, there's a big printout in your book for that on page 851, figure 47.9. You can look at that. And like I said, surgery will be delayed until those acute symptoms subside. So if they think it's necrotic or there's an extremely high white blood cell count, or if it's really inflamed, because we don't want to open the patient up and have that infection spread. So 80% of the time we go in and we do what's called a laparoscopic cholecystectomy. So in your book, it also talks about that, page 851, you can see that. They go in and they make about 1, 2, 3, 4 or 5 incisions laparoscopically, and they visualize what they're doing with these little, they kind of look like crochet hooks, and they can see it on the screen. They go in and they just suck it out. It's very simple. It used to be that laparoscopic was 1 day in the hospital. Now it's outpatient. You come in the morning, you go home. The big take-home educational piece with this is that we have to inject a lot of air into the stomach when we do this because of all the organs. We have to move all the organs out of the way so that we can actually visualize the liver and the gallbladder. So when we are done with the surgery, that air is still in there. So that pain is excruciating. Like most patients say that the trapped air pain is worse than the pain from the actual incisions. So we really want that client to get up. If they stay on the unit and they stay overnight, within an hour of getting to the unit, we want them up and out of bed, even though it's painful. You can also give like simethicone to help them burp or help them have gas to get rid of it. Sometimes if they get in there laparoscopically and they see that it's too inflamed or that there's something wrong, they can't do it laparoscopically. They have to come back out and they have to do an open cholecystectomy. This requires an abdominal incision. I'm not sure which way they do it nowadays. At one time, they used to do it up and down. And then for a while, they were doing side to side. So I don't know if it's just a doctor preference, but either way, they have to make an abdominal incision and go in. So this is going to require a hospital stay for sure, because it's a major surgery. That's 20% of the time. Sometimes they don't do a laparoscopic and they realize it. Sometimes they just know from the lab signs and the studies that they've done that it's severely infected or there's something going on and they can't do it laparoscopically. So educational piece with this is that we want these patients to be very careful when they advance their diet. So because it's major surgery, they're having general anesthesia, we're going into that area, peristalsis can be slow to return. So we want them to start with clear liquids and then advance their diet to solid foods. So nursing diagnoses, we could see nausea related to the obstruction of that bile and that bile building up, imbalanced nutrition, less than body requirements related to anorexia, nausea, vomiting, acute pain related to obstruction of that bile flow and inflammation of the gallbladder. Once they have that cholecystectomy, we could have imbalanced nutrition, less than body requirements related to high metabolic needs, and decreased ability to digest fatty foods, acute pain related to trauma from surgery, risk for deficient fluid volume, risk factors, restricted intake, nausea and vomiting, risk for surgical site infection, risk factor, invasive procedure. All right, so to finish up the night, looks like we're going to be talking about patients with ostomies. All right, so an ostomy is a surgical opening that we make from the inside of the body to the outside of the body in different areas of the body. So we take the mucosa on the inside of the belly and we pull it to the outside. That creates what we call our stoma, which sits on the outside of the abdominal area. We can have an ileostomy or a colostomy. So an ileostomy is a surgical opening into the ileum to drain stool, which is typically frequent and liquid since it bypasses the large intestine, okay? The amount of the consistency of the stool that you have is always going to be in relationship to where your colostomy is. So if you have a colostomy, that is a surgical opening in the large intestine to drain stool, with the ascending colon being more liquid. The transverse colon is going to produce more formed stools, and then the sigmoid colon is going to produce near normal stool because it's closer to the colon. So that stoma is the artificial opening created during the ostomy surgery. You can see it there in the picture, that little beefy red ball on the outside of the abdomen. We do this for a variety of reasons. Sometimes it's temporary, sometimes it's permanent. We can do it for inflammatory bowel disorders to give the bowels a rest. If the patient has a rupture in their intestines, if there's irreversible obstructions, any kind of compromised blood supply to the intestines, which causes it to be necrotic, or we see it a lot in patients that have colon cancer or some type of tumors. Oh, excuse me. All right, so a permanent ileostomy is a removal of the entire colon, the rectum, and the anus. Temporary ileostomy is removal of all or portion of the colon, but the rectus, I can't talk. These 4-hour lectures are so long. The rectum and the anus remain intact. So with the permanent, it's in the entire colon, the rectum, and the anus. The temporary is all or a portion of the colon, but the rectum and the anus remain intact. We have a matured stoma. In order for that stoma to become matured, it's a process. It takes a while for that to heal. It takes a while for the skin around it to heal. It's a process. It takes some time. It's different for every person. Eventually, once that stoma is healed, it should be very smooth, beefy red, and look very healthy. The fecal material that comes out, you might have some digestive enzymes. It could be liquid. It could be more formed, depending on where it is. We're going to talk about different appliances and different supplies that we use for ostomies. There is something called Caraya gum. Most patients that have colostomies use this or some other type of protectant. When we put these bags on our patients, we always want to think about skin integrity, because if it doesn't fit right, the stool can leak out and get around the skin. And if you have diarrhea and the stool touches your skin, how raw your skin can get. Well, the same thing can happen on your abdomen. So if the bags aren't cut properly and that stool sits on there, or just from having the bag and that adhesive on your skin all the time, it can break down the skin. So we want to use products that protect the skin and help promote adhesion of a well-fitted bag. So during the preoperative period, before we actually do the ileostomy, the doctor is going to come in. They are going to talk to the patient about the surgery. So they're going to explain to them exactly why do they need to have an ileostomy? Why is this the best choice? Why are we doing this? What are the benefits to having this done? But then we also want to tell the patient about the risks. So they have to sign consent to have this procedure done. They usually decide where they're going to put the stoma. So they visualize it on the outside of the body. They mark the site where they're going to do it with a marker made just for the skin. They're going to explain to the patient what the stoma is going to look like and what the function is going to be, where they're putting it, what their stool is going to look like. Some of the things they think about when they decide, they want to make sure it's unobstructed and visible to the patient. So the patient, usually the patients maintain this themselves. There's a small population of people who are older or who have some type of issue where they can't, but a lot of these people do take care of this themselves. So we want the patient to be able to see it so that they can maintain proper care of it. And then we always want to make sure that it's away from any kind of bony prominence, so where their hip is, any skin creases or any scars, because we want to always be able to put that bag on easily, have it be like in a great area. So sometimes if it's too close to the belly button, then it's not going to stick, because the belly button is like kind of an opening. So when you put that ostomy over top of it, when you put that bag, you're never going to have a good seal. So it's always going to leak. So you want to avoid things like that. So a lot of thought goes into why they have to do it and then also where they're going to put it. So there are a group of people who are called enterostomal therapists, enterostomal therapy nurses, and wound ostomy and continence nurses. So these women are amazing. This is what they do. It's what they love. It's their passion and they're good at it. They come and they help the doctor sometimes with marking the placement of the stoma. They collaborate with the surgeon and they will do a lot of education with the patient. So they'll do a lot of education pre-operative to let them know exactly what to expect. Once they have the surgery, they're going to come visit them again in the hospital and then give them more education. And then once they go home, they're going to follow up with them in the, through home care to make sure that they're able to handle it and that they're having all their questions answered and that they're getting all the education that they need. So education is a huge piece to this. The surgeon, like I said, will explain the benefits, but they're also going to explain the risks. So sometimes you could have bladder dysfunction or sexual dysfunction because they do damage to the parasympathetic nerve during the surgery. So we know everything comes with a risk. So we want to talk to men about the possibility of sexual dysfunction. Highly unlikely, but it is a possibility. So sometimes men will opt, if they're in childbearing years or in the time where they are thinking about having children, they might want to collect and store their sperm. There is a small amount of risk for infertility in women. We want to make sure that they cleanse the bowel before surgery really well, adhere to any dietary restrictions. So if they're NPO, sometimes I told you earlier that different doctors use different bowel preps. So Go Lightly, Miralax, Ducalax, whatever they use to completely clear out the colon, obviously, before or the intestines before they have this surgery. We will give them antibiotics prophylactically to avoid any type of infection. And if they had any kind of infection going on, they might just get them afterwards as well. If they are on prednisone right now, remember we said that sometimes they can have different issues that cause a lot of inflammation, so they have to have prednisone. So prednisone can make it hard for tissues to heal. So if possible, you want to taper down or discontinue your prednisone. And sometimes preoperatively, the doctor may give what they call a stress dose of an IV steroid. So we give this to patients who have been on prednisone within the last 6 months to prevent what they call an adrenal crisis. We're going to talk more about that in metabolism. So if they're going to have surgery, they need to discontinue immunosuppressive agents 3 to 4 weeks before surgery. We want to prevent any negative effects on tissue healing. If they have aspirin or any kind of medication that contains aspirin, they want to stop that medication 1 week before surgery to minimize the risks of bleeding. And then we always want to obtain blood samples, types and screens and cross matches in case they go to surgery and they lose blood. We want to know ahead of time what blood type they are and any cross match. And sometimes patients can even donate their own blood as well to keep it in the hospital in case they need it. So the post-operative period. So now the patient has had the ileostomy. What are we going to do? So usually these patients will have a rectal pack. The doctor goes in and they pack it with some type of gauze. It absorbs any drainage that's in there and it promotes healing. Usually this packaging stays in for 5 to 7 days and then it is removed. We might do irrigations through the stoma, sometimes to promote healing. They might need a nasogastric tube or nasogastric tube to decompress the GI tract until the normal bowel motility starts to resume, because remember they're having surgery and we're messing with their bowels, so it's kind of like a double whammy. If they're still NPO, they might need IV fluids, electrolyte replacements. We're going to make sure that maybe they're getting TPN depending on how long this process is. If they need IV therapy, IV antibiotics, we're going to give them antibiotics. We're going to make sure we're giving them medication to help control their pain because they did have a major surgery. We want to monitor for wound healing. So we want to look at that site. Every time we're in the room, we want to monitor the bowel movements that are coming out. If there are any, we want to make sure that that stoma is beefy red. And we want to make sure that that skin around it is healing nicely. And then we want to manage any type of complications that can arise. So the patient is at risk for developing an intestinal obstruction. This would be an extremely serious complication. Obstructions can result in perforations. They could have bleeding as a side effect, and then we could have an impaired blood supply or stenosis or prolapse or excessive protrusion of the stoma. So we're going to talk a little bit more about that, I think, on the next slide. All right, so normally our stoma is dark, beefy red is how we call it, and it's usually moist. An abnormal stoma would be, if it was paler, purple, blue, a grayish color, that would mean that no blood flow is getting to it, and that is a bad sign. Sometimes we might have to go in there and irrigate it, depending on what's going on. You can see the skin around that stoma is irritated. It is actually, we're having some protrusion there or prolapse. So sometimes it is common for that to happen. You can have a prolapse or a protrusion. If it's moderate, so only 1 to 2 inches, they don't do any type of treatment at all. It usually just resolves itself. If it's severe, then it's a serious complication and they have to go in and do some type of surgery. Sometimes we can have edema just from the process of the surgery, which should be a common finding, but if it causes too much swelling, it can cause obstruction and it can restrict that blood supply to the stoma. And then if we don't get proper blood supply or if the prolapse is not managed and identified quickly, the stoma can become necrotic and it can be dead and we won't be able to do anything to save it. And then also once we have a stoma that prolapses, it's very likely that it's going to continue to recur again over the course of them having this stoma. So you can look on page 870 of your book. Table 48.2 talks about characteristics of healthy and unhealthy stomas. So these patients are going to have to undergo some dietary changes. So they are going to have to avoid food or know that food like fish, eggs, asparagus, garlic, beans, and dark leafy vegetables can cause odor. It can cause odor in their bag. So what happens is they still get gas just like we do, but their gas fills up in their bag. So you'll go in the room and their bag will not have anything in it, or it could have a little bit of stool in it, but it'll be really swollen. So you have to do what we call burping the bag. So you have to open that bag. Awful, awful. The worst smell. I'm not kidding you when I say that I can be in this room and burp my patient's bag and somebody could be down the hall in a whole nother room and smell it. It's bad, really, really bad. I don't like ostomies for that reason. So you have to educate the patient that they want to try and avoid these foods as much as possible. They can use buttermilk, cranberry juice, or parsley and yogurt to help decrease the odor in that bag from all the gas they get. Green leafy vegetables cause gas, beer, carbonated beverages, dairy products, and corn. These are things that a lot of people like to eat. So maybe they won't want to give it up. Maybe they will. It just depends on if they can deal with the gas or not. Chewing gum, skipping meals can cause gas. Yogurt, crackers, and toast can be ingested to help decrease the gas. And then after they first get this ileostomy, it's really important that we educate them about avoiding high fiber foods for the first 2 months of surgery. We want them to chew their food very well so that it digests easy. We want to increase their fluid intake, and then we want to evaluate for evidence of blockage when we start adding in those high fiber foods to the diet, because it would be very easy for them to get a blockage. So we want to make sure that we are assessing the type and the fit of the ostomy appliance. So patients, there are so many different types of ostomy appliances. I mean, even just the ones that you carry in the hospital, the manufacturers are always changing. The hospitals are always carrying a new one. I feel like I don't see them an awful lot. And every time I do see one, when I go to the supply closet to get something, it's a whole new thing again. And I have to read the instructions and learn how to use it. And another thing is that some of these patients that have had ostomies for a very long time, they bring their supplies with them. So you have to learn to use their appliances if it's something that they don't change on their own. Like I said earlier, a lot of people do change their own, so that's nice. You don't have to do it while you're in the hospital, but that's not always the case. So we always want to monitor for leakage. So ideally, we want to be very proactive when we go in. So we kind of want to treat this as like a Foley. So every 3 to 4 hours, we should be going in, looking at that bag, making sure that it's not full. We don't want to wait till it's full to change it. My rule of thumb is like a third to almost half full. I like to change it because I would rather change it and I would rather empty that bag 8 times a day than have to change all the linens and clean up an explosion that happens because the bag hasn't been changed. So you want to make sure you're assessing that area around the skin. Make sure that you're making sure that the stoma is beefy red, that it has good blood flow. When you change the bags, you want to make sure you're putting those skin barriers on there and any creams that help adhesive paste that help moisturize the skin and protect the skin from breakdown and help those bags really adhere to the skin. When you do put those on, there's a drying time, which some people don't realize. So at our hospital, we just have little things that look like alcohol pads. We rip them open and we go all around the area where we know where we're gonna put the bag. It takes about 3 to 5 minutes to completely adhere to the skin and to completely dry. If you don't wait for it to dry, you're gonna come back in a couple hours and the bag is gonna be off and there's just gonna be poop everywhere. So really take the time to make sure that that dries before you put that bag on. We should always be evaluating the stoma output. So just because they have liquid stools doesn't mean that they should be having 10 or 12 bags filled a day. They can still have diarrhea. We still might have to give them some type of diarrheal medication. They can also get constipated. We might have to give them an enema through their stoma. So all the same issues that happened before can happen now. So we want to know if they're having a lot of liquid stools, how much are they putting out? So it's easy if they have a stoma because you can measure it in a graduated cylinder. Output should be more liquid and more acidic the closer the ostomy is to the proximal small intestine. So yeah, right here it says empty the ostomy bag when it's 1/4 to 1/2 full of drainage. And then you always want to evaluate the ability of the client or the support person to perform the ostomy care. So this can be a very, very difficult thing for a person, especially if this is the first time that they've had one. It requires a lot of education. Some patients don't want to look at it, so especially if they're younger, they feel like it's going to affect their sexuality. They feel like it's going to affect their relationships with people. They don't feel sexy. They don't feel attractive. They're intimidated by it. They're grossed out. It's a whole combination of different feelings. So you really have to be empathetic. You really have to listen to them. The first day that they have an ostomy is not a good idea to go in and say, here's a graduated cylinder. Let's work on you draining it. You don't want to do that the first day. Give them time to get used to it. Let their pain level decrease a little bit. Maybe by the end of the second day, start talking to them a little bit about it. This is how much output you're having. This is what your stool looks like. How about if we plan tomorrow after you eat your breakfast that we'll do some one-on-one education. You can bring in, if you don't want to show it on them, the hospital usually has some type of a a dummy that has a bag that you can use because they don't want to look at their own. So you can use the dummy to just, explain different things. So there is a process, and it is a period of time that you want to give them to be able to accept this. Disposable. So I told you there's a whole bunch of different type of appliances. Some of them are reusable. Sometimes you just change. So if you see this little portion right here on the back where it says stop and cut, sometimes that is removable from the bag, and that piece we put on the skin, and we can remove the bag and just keep that piece. Sometimes it's not a 2-piece, it's just a 1-piece. So you can just empty the bag, but then when the bag is not good anymore or it becomes compromised, you have to change that whole thing. So there's a variety of different things. Sometimes these ostomies are temporary. Sometimes they are reversible. They'll only have them for a certain amount of time. Some people are particular about when they like to be replaced, even if there's nothing wrong with them. Maybe they want them replaced daily. If that's something they're used to doing at home, we want to accommodate them at the hospital and do that at the hospital as well. We want to stick to their normal regimen as much as possible and try and use the equipment that they're accustomed to. If they don't bring their stuff, unfortunately, they just have to use what the hospital has, or they have to have a family member bring it from home. So one type of an ileostomy is called a continent ileostomy. It's also called a cock pouch. It is where they go in and they create an internal reservoir for the storage of GI effluent. Excuse me. The stool actually stays within the body for several hours until the patient decides to remove it. It eliminates the need for an external appliance, which makes people feel better about themselves. They go in, the patient goes in, and they use a catheter to go in and drain the stool. Usually, there's a temporary catheter that stays inserted for the first 10 to 14 days. Then that comes out, and then the patient will go in and kind of like people self-cath themselves for urine, they do the same for the stool. And then usually after this is created, there's a perineal packing that stays in for about a week, and then it is removed.
Excuse me, Renee's trying to get in. She got kicked out again.
Okay.
Thank you.
So there's something called an ilioanal reservoir. This is usually performed in 2 stages. So the first stage, the surgeon will go in and they're going to create that temporary ileostomy. They remove usually a large length of the diseased colon down to the terminal section of the rectum, which is usually just above the anal sphincter. It joins several distal loops of the healthy ileum to form a pouch that will hold stool. And then it connects to the ileal reservoir to the anal cuff. Then 2 to 3 months later, the surgeon goes and closes the temporary ileostomy and reunites the 2 sections of the ileum. The area where the 2 sections of bowels are joined is now called an anastomosis. The anastomosis establishes a normal flow of fecal material through the ileum to the reservoir. The fecal material is expelled, and the sphincter, they now have a stronger anal sphincter. It helps, an advantage to this is that it helps maintain bowel continence. This is used in patients that have ulcerative colitis or diseases that do not affect the anorectal sphincter. This is a good option for men because it preserves the innervation in the male genitalia, and it can, bladder and erectile dysfunction and infertility are highly unlikely. So this is another added advantage. So nursing management, preoperatively, it's going to be everything that we do for the ileostomy. Post-operatively, during the first stage, we're going to make those same observations and assessments as those that had the ileostomy. We're going to make sure we're observing for any type of anal drainage. And then we are going to drain or put a drainage tube in that pre-sacral area so that we can get rid of all the drainage. In the postoperative second stage, again, drainage is going to be our big issue. We're going to be observing for that and make sure we're draining it. And then we're going to be maintaining that anal area and any operative sites, maintaining, make sure that it's clean, dry, and there's no infection, controlling the drainage. And then these patients are going to have a list of perineal exercises that they need to perform probably about 2 weeks after surgery. So we want to educate them and make sure they are doing those exercises. And then we want to talk to them about bowel incontinence and how imperative it is to keep that peri area clean because we don't want to have any infection. The ilioanal reservoir postoperatively, the first stage is we're going to postoperatively, we're going to teach that client to use a squirt bottle. They're not going to be able to take any baths. We really don't want them to take a shower. So in order to clean that area, we usually give them a squirt bottle or a spray bottle to really clean that perineal area and to avoid any kind of skin irritation. After that second stage where they go and they do the repair, then that client can start cleansing the anus with warm soapy water. They're not going to just use that squirt bottle with warm water anymore. And then we always want to make sure that they are emphasizing to keep that area as dry as possible. It's a dark area. When it's wet, bacteria can breed. We don't want any type of infection. So some nursing diagnoses that we might see for the ileostomy are disturbed body image related to presence of a stoma, diarrhea related to dietary changes, alteration in intestinal motility, deficient knowledge related to limited practice of stoma care, dietary modifications, social isolation related to alteration in physical appearance, fear of accidental spill of ostomy contents, social isolation related to alteration. Oh, we said that, sorry. If Martha Lynn tries to get back in again, just let me know. I tried to, but she wasn't there anymore. Risk for impaired skin integrity, risk factors, difficulty obtaining tight seal of the appliance, and caustic drainage. So then we have a colostomy, which is where we go in and we make an opening in the large bowel, which is created by bringing a section of the large intestine out of the abdomen, and they make a stoma from it. We do this for patients that have had cancer, ulcerative inflammatory processes, patients that have a lot of polyps. Polyps can turn into cancer, any kind of injury to the bowel. There's a couple different types. It all is according to where they're placed. They can be temporary, they can be permanent. They can be in the ascending, the transverse, the descending, or the sigmoid colon. And a stoma may be found anywhere from the lower right center to the middle to the lower left positions on the abdomen. Page 872, figure 48.5 talks about placement of ostomies in your book. So you guys should read that. So the consistency of our fecal material is going to be determined by the type that we have where it is. So it can be from semi-liquid to formed depending on the intestinal area where that colostomy gets formed. Some of them need regular irrigations to help control the sigmoid and the descending colostomy. We can have different appearances. There can be a single barrel, a double barrel, and a loop. These are all listed in your book. You guys can look in your book to get some pictures. So a single barrel is a single stoma. The colon is cut just above the area that's diseased or wherever there's a problem or a tumor. The healthy end of the colon is then brought through the abdominal wall to form that stoma. Sometimes we have a segmental resection where the diseased portion of the bowel is going to be removed with the remaining distal end closed for later reconnection. So sometimes they have to allow healing to occur. So you have to wait until that has taken place and then they go in later and reconnect everything. And then we can have an abdominoperineal resection. We see this sometimes in patients that have tumors in the lower third part of their sigmoid colon. So a double barrel is performed most often in the transverse section of the large intestine. It contains both a proximal and a distal stoma, so two of them. The proximal stoma expels the fecal material. The distal stoma leads from the lower portion of the cut bowel to the anus. The physician must clearly identify the distal and the proximal. The nurse will want to duplicate the medical diagram that the doctor drew out into her care plan so that she can recognize where she's going to assess bowel function and where irrigations are going to be required based upon the distal and the proximal areas. So this is, A is your sigmoid colon. So if you had an ostomy there, it's going to be solid, right? Closer to the colon. The anus is going to be more solid. B, that's your descending colon. So still in that area, they're going to be semi-mushy. C, this is your transverse colon. So they're going to be even mushier. And then D, this is your ascending colostomy. So your fluids here are going to be all liquid. So we would do colostomies temporarily to treat different disorders. So acute diverticulitis, chronic constipation, or any type of inflammatory bowel disease where we just need to give areas a rest. There usually is an interval before we start reestablishing a connection again. Usually it takes about 16 months or longer. We can do something called a loop colostomy. So a loop colostomy involves lifting a loop of the bowel through an opening in the upper abdomen. The loop is supported in place by either a plastic rod or what they call a bridge. An opening can be created at the time of surgery, or they can go back in 24 to 72 hours later after the procedure and create that opening. When opened, there are actually two openings, one for the proximal end of the colon, which is going to excrete loose to soft feces, and the other at the distal end. And usually nothing but mucus comes out of the distal end. Usually they'll go back in 1 to 2 weeks and they'll remove that plastic rod or that bridge, whatever was used. And then the client always wears a pouch for stool collection. It's going to be permanent. So patients that have a loop colostomy, when we're managing them, and this is for anybody, but you always want to make sure you protect the bed and the client's clothing when that colostomy is open or you're changing that bag, because some colostomies are perfect. You'll wipe them off and everything's clean and it'll stay like that the whole entire time you're putting the new bag on. Some of them will just drain a little, and then some of them will just constantly have stool coming out of them. And it makes it hard to keep that area clean. So what I like to do is I like to have towels around the patient on the bed. I don't want to have to change everything. And then I'll usually bring a washcloth too that I will cover up the ostomy with to kind of suck up that stool while I'm cleaning the other area and keep it, clean. You want to prepare the client, obviously, especially your patients that are new to this, that don't know about how bad it smells. So your newer patients require a lot of education, their family members. If you have a temporary ostomy, you want to explain to them that it's going to be temporary, what their flow of feces is going to look like based upon where it's placed. So preoperatively, this is going to be the same as the ileostomy. The first day post-operative, it's completely normal not to have any feces in the collection bag. They probably haven't had anything to eat, and it takes a while for that peristalsis to start moving again. Patients can have a lot of anxiety, for one, just because they have this new thing that they have to learn to manage, or if they have some type of cancer, obviously that can cause anxiety as well. Usually they can start eating a regular diet, but like we said, we want to avoid those gas-forming foods to help control that gas. Eat slowly with the mouth closed and chew food well to help decrease gas, because we do swallow a certain amount of air when we're eating. And then we want to make sure that we're checking their body weight weekly, because we want to make sure that they are not having a sudden weight gain or a loss. So weekly body weights. And then lastly, nursing diagnoses, disturbed body image related to presence of stoma, daily care of fecal material, social isolation related to anxiety about appearance of stoma and possible leakage of stool, risk for constipation, risk factor inappropriate diet, risk for diarrhea, inappropriate diet, risk for impaired skin integrity, irritation from the bowel contents, and readiness for enhanced knowledge. They are expressing an interest in learning. And that is it.